very good morning to you all and a warm welcome to our Allergy UK webinar, Food Allergy in the Spotlight. My name is Laura Phillips. I'm a clinical dietetic advisor at Allergy UK. I work for the clinical team. I'm also a paediatric dietitian in the NHS for the rest of my time. We're very, very excited to be joined by up to 700 delegates today. We have a fantastic lineup of speakers and we really appreciate their time taken out of clinical practice and education today to join us. We ask you to interact with the Slido platform with polls and questions during the presentations. We aim to have around 5 minutes of questions at the end of each presentation, and we'll try to cover as many questions as we can for you. The presentations are amazing and we look forward to hearing from them. We just want to start off taking 5 minutes to learn a little bit more about what Allergy UK can offer to the allergic public. So we're delighted that Allergy UK have been around for 30 years. It's our 30th anniversary this year, and we've been providing support and advice for people living with allergic disease throughout that time. We are the leading UK-wide patient charity and we cover all aspects of allergic disease, whether this is immediate allergy, delayed allergy, asthma, eczema. We work with all aspects of allergy and we collaborate with allergists, immunologists, dermatologists and other healthcare professionals to make sure all information provided is research-based, evidence-based and provides the best information. Our vision at Allergy UK is no one should die of allergy. Our mission to achieve this is for everyone in the UK to take allergies seriously, and our goals are to empower, educate, research and influence. We are the voice of the allergic public and we're there to provide however we can. So why do people need us? There are 2 million people living with allergy within the UK. This is a huge amount of people. The need cannot be met by the NHS alone and people seek out help in other ways. We would make sure that they get the best information however we can give it to them. We provide information to parents of food allergic children, adults with allergic disease. We give information to schools and healthcare professionals. We try to raise awareness of conditions and the impact of the quality of life, and we're there to inform and advocate on behalf of the allergic public. So how do we do this? So it's really moved forwards in the last few years. We've got an amazing comms team who manage our social media accounts. We've got Facebook, Twitter and Instagram. We have really good reach and engagement with the allergic public. We post every day and get a lot of feedback from that, how we need to move forward as a charity. I'm sure you're already aware, but we do have a helpline that's available Monday to Friday. Our helpline staff are empathetic, amazing, and always there to answer the needs of the allergic public. For the majority of queries, they can answer everything that's possible. If there are complex queries, they'll escalate it to our in-house clinical team, which will be answered where possible. And if there's further ask, which we're unable to answer at Allergy UK in-house team, we've got a health advisory board, which has 44 specialists, including allergy specialists, immunologists, dietitians, pharmacists, dermatologists, and primary healthcare professionals who can always answer any queries that we can't. We have thousands of helpline calls and emails every year. We try to answer however we can in the best possible way. We liaise with the Food Standards Agency and we send out alerts to our database if we think there's been a problem with a certain food, if there's cross-contamination, to try and keep the food allergic public safe as possible. We have a huge number of fact sheets on our website. If you haven't visited our website recently, I would really invite you after this webinar to have a look. We've tried to rebrand and look at it so that the information is easier to search. It's much easier to get the information quickly based on what you're looking for. We have over 70 fact sheets. These are all peer-reviewed and research-based and reviewed on a regular basis. The information is top quality and we ensure we're always giving the right messages. We're always developing new research resources are leaflets and fact sheets, some of the newer ones, the top 10 facts about food allergy or anaphylaxis, the 4As. They're really amazing resources with lots of pictures and really easy to understand information. We're also moving forward with atopic dermatitis resources, and there's some additional information on other food allergy and other allergic resources. So please do have a look if you haven't looked recently. So it's not just fact sheets, and we're trying to move forward also in other ways. We've got some podcasts for healthcare professionals, which you will find on our website. If you've got half an hour free, if you're going for a run, doing the ironing, have a listen. They're very informative and give us some really good messages. For the public, we're trying to work towards some videos so the messages are seen in different ways, in clear, understanding messages. We do have collaboration with external stakeholders for surveys and also in-house surveys to always understand how we can make sure we're moving forward for our allergic public. We will publish this information and try and make change in a positive way however we can. We do extend our influence in other ways, and we do work collaboratively with lots of external agencies wherever possible. We're on our AllergyUK website for healthcare professionals. Please do visit. We've got lots of information. You'll be able to find future webinars in that at the moment. You can see if there's some further ones you want to sign up for. We've also got a biannual publication with research articles to have a read of. The next one's due out very soon. And we've got information how you can seek further advice. After today, we would like you to complete your evaluation form, and on completion, you'll get a certificate and CPD points. All your feedback is always really helpful, whether it was useful for you and what you would like to see in the future. The running order of today is we're going to be setting the scene for food allergy with a focus on FPIEs with after that, some practical management of milk allergy. We aim to have a short break around 11 to 11:15. We move on to peanut allergy and the psychological impact of food allergy after the break, and then at the end, hope on the horizon for food allergy. We aim to end the session around 1:15 today. So it's my absolute pleasure introducing Dr. Gary Stifel. He's a paediatric allergy consultant at the University Hospital of Leicester. He is really a leader in paediatric allergy, and he's recently done some interesting work on FPIEs. We hope you find his presentation informative.
Hi, hi everyone. My name's Gary Stiefel. I'm a paediatric allergy consultant, and I'm also a trustee for AllergyUK. So hopefully I'll set the scene for food allergy over the next sort of few minutes. And thank you for the introduction. You can see a bit of sun shining in Cambridge where I am at the moment. I'm sitting in my office because I managed to rupture my Achilles tendon playing football. So I've officially entered middle age. Anyway, without further ado, the aims of this is really to set the scene, talking about prevalence of allergy. I'm going to talk about IgE, so-called immediate and non-IgE mediated allergy. And then that will be the bulk of the talk, and trying to come through some cases to provide illustrations of that. And then we'll talk about FPIEs and how this fits into the picture. And I'll give an introduction to FPIEs diagnosis, treatment and management. So I won't spend too much time on prevalence, but just to say, if you look on the far right-hand side, this was studied on my Grimshaw, looking how common is food allergy. So it is pretty common, about 5% of children or infants. So it's common. However, the perception of food allergy is much higher. So what I'm hoping to do is try and help you to be able to sort of, in a sense, identify the actual true allergic children. I'm going to, just to say, I like this slide, just to say, the way I think about food allergy, it's very much an adverse reaction to food, which involves the immune system. So if you take on the left-hand side, so food intolerance. So if I gave you all sort of maybe a couple of pints of beer, you may be absolutely fine. Some of you will have an effect of that. If I gave you all probably 20 pints of beer, you'd all have an effect. And that's sort of the pharmacological effects of alcohol. Similarly with caffeine, you'd have the effects of that. That's not an allergy, that's an adverse reaction to that product. Similarly with, I suppose, with sort of instance with lactose intolerance, if you've had normally gastroenteritis, then you struggle to digest sort of things like milk with lactose in, that's also due to shedding of the brush borders of the intestine, and that's not due to allergy. So when we talk about allergy, I'm going to focus very much on the IgE mediated and then the non-IgE mediated, so that's an adverse reaction to food which involves the immune system. And IgE mediated is a very nice model, we understand that very well. Non-IgE, we're getting much better understanding. Having said that, the tests are not using any immune tests. So these are the commonest IgE-mediated food allergens. So I think if you remember this, it's a good starting point, because this covers 90 to 95% of all the food allergy that we see. So that's milk, soya, egg, peanuts, tree nuts, wheat, sesame, kiwi, shellfish, and fish. And that covers most of it. So actually, things like tomato are actually extremely uncommon, although it does cause an irritant reaction, but equally, due to natural histamine, it can mimic an allergic reaction. Equally, things like oranges, again, very uncommon, but often in children with eczema, it will flare up the skin. That's not allergy. And I think more so, in Leicester, we have quite a big Asian population, so we see a fair amount of legumes, so lentils, chickpeas, allergy as well. So those are the bulk of the IgE-mediated allergens. And then we have the non-IgE, and by far the commonest is milk. And in about 30% of children with milk, there's soya, but soya can be in isolation. And then we see some wheat and some egg. But those are very much the most common. It's unusual to get other foods. So I have to thank my colleague in Southampton who I trained under with Michel Lajeunesse, and he has this so-called the anatomy of the allergic reaction, the eater's history. And really, I think the most important thing is, number one, to think about the environment, then think about the actual allergen. So if it's not an unusual allergen, you have to question, could it be allergy? The actual exposure, so was it by the skin or was it by ingestion? And the timing is so important to get right. So I can't emphasize that enough. If you don't ask the timing, you may get things wrong. Ideally, whether it's reproducible, although you don't always get a history of reproducibility, it may just be the first time they've had that food. And then finally, the symptoms, are they typical symptoms? So for an IgE-mediated reaction, so let's say exposure would be eating or occasionally by skin contact, but very rarely by inhaled food. And the exception to that is probably fish. When it's cooked, that can potentially cause more significant reactions. But things like peanuts, and this worry about peanut causing it, sort of aerosolized reactions, is extremely uncommon because it's a heavy molecule. We've talked about the typical allergens. The timing normally causes very quickly, but certainly at least within 1 to 2 hours of ingestion, and occurs often during weaning or and first known exposure. The environment, so if it's a new part of the diet, normally at weaning, eating out at restaurants. Reproducibility, it should always have symptoms when you're exposed to it. And then compare that to the non-IgE. So often it can be if you're breastfed or if you're eating the food. The most common allergens are milk and soya. Timing, it can be quite variable. It's normally several hours, potentially even 3 days. And also very commonly occurs in the first year of life. So it's unusual to suddenly develop a non-IgE mediated allergy at several years of age. Onset can often be insidious, and the allergen is normally a regular part of the diet. Symptoms may take time to settle on exclusion diet, so potentially takes 2 to 14 days, but often will go for a longer exclusion diet. You often get eczema symptoms and very much gastrointestinal symptoms, so fore and midgut symptoms like vomiting, reflux, colic, and then hindgut, diarrhea, constipation, mucus or bloody stools. And then sort of you can get vomiting and diarrhea, and I think what we're getting at there, you get profuse vomiting, and I'll talk about that a bit later. So it's really a balance from the history, and you're really using your history to determine what you do next. And I can't emphasize that enough. It comes down to, with anything in medicine, it comes down to your clinical history. So I hope that's useful in giving you a few tips from your history. In terms of your investigations for allergy, you have very much your IgE testing, so previously called RAS testing or skin prick testing. And if you still haven't got a decision following that, you have the option of doing challenges, and often it's open food challenges. We very rarely do blinded challenges, and the bottom stands for double-blind, placebo-controlled food challenges, which is almost exclusively in a research basis. And these investigations are very much for IgE-mediated allergy. Just to say, so what do the skin prick tests reflect? It really reflects IgE bound to cutaneous mast cells and then subsequent release of histamine, such as histamine. So it's an in vivo test, whereas specific IgE just reflects IgE within the bloodstream. So it's very much an in vitro test. So I'm going to go through a few cases and give you a few seconds just to consider it, and then I'll talk you through these examples to try and give you examples of cases I've seen in the last few years. So a baby who's exclusively breastfed has got mild eczema from 4 months of age. At 6 months of age, has some baby porridge. 5 minutes later, develops a red rash on the body. It looks like a nettle sting rash, so it looks like hives, raised white areas, and it's itchy. He's irritated. He vomits, and 1 week later, tries it again, and the same thing happens. So the allergen information is covered here. It's got ingredients, and you can see the things in bold are milk, and then emulsifier, so soya lecithin, and that's a very sort of small amount of soya. So thinking about your diagnosis, would you be thinking, could this be a non-IgE mediated milk allergy, an IgE mediated milk allergy? Could it be reflux, or could it be another diagnosis? I'll give you a few seconds to consider that. So I think very much think about that. That's very much thinking of an IgE-mediated history, because the exposure was due to eating. The allergen is most likely to be milk. I think milk is much commoner than soya. And soya lecithin, even if you have soya allergy, you often can tolerate that. Not always, but often. I think the timing was quite quick, within 5 minutes. It was sort of at first exposure. The environment was a new allergen part of the diet. It was reproducible, happened a week later. I think the history is in keeping with that. So what do you do next? Do you do a specific IgE to milk? Do you say, well, we can't do a skin nasal IgE because the child's not 12 months of age, so you wait then? Do you diagnose an IgE-mediated milk allergy? Do you diagnose non-IgE-mediated milk allergy, or do you refer to a local allergy team? So I think on the basis of that, I think in a sense, what you would be probably doing depends on your competencies. You may refer to a local team, but what I'd hope you'd think is actually it's a history suggestive of IgE-mediated allergy. And although there's reproducibility, the likelihood increases as there's reproducibility. So having said that, you can't rely on just on your clinical history. So you really should do a test to confirm your diagnosis rather than to make the diagnosis, so just more to confirm. So you do a specific IgE to milk, or you could do a skin prick test to milk. There's no need to wait until 12 months of age to do the test. There's no evidence to say you can't do a test in a young infant. So I've just changed the case a little bit to make it case 1B. So take a baby who's exclusively breastfed, has mild eczema from 4 months of age, so the same as other history. At 6 months, has baby porridge, but this time we're saying 5 hours later, develops a red rash on the body. It's a nettle sting rash, hives, and the baby's just recovered from a viral upper respiratory tract infection. So I think the key thing from here is really just being aware the timing, although the history, everything fits in, what is different is the timing is a long time. So you could think, well, could this be non-IgE-mediated allergy? Well, non-IgE allergy does not result in hives. Equally, this child's recently had a viral infection. The timing is wrong. It's 5 hours later. So this is very much a case of a viral urticaria, which can mimic an allergic reaction, but it's not due to the food. So I think you can safely say this is not allergy, and actually the treatment of an urticaria secondary to viral infection would be using antihistamines. And even in a baby, you can use cetirizine. The dose would be 0.25 milligrams per kilo, and that's what we'd recommend rather than Piriton, which can make you drowsy, so chlorphenamine. So case 2, a baby presenting at 3 weeks of age, exclusively breastfed. Mother reports lots of symptoms in her baby. The mother has a history of hay fever, but father has no history of atopic conditions. So I suppose the question to you, is it possible for this baby to have a diagnosis of a cow's milk allergy? Yes or no? So again, I'll give you a few seconds to think about that. So very much this belief that you can't have a milk allergy, sort of if it's via breast milk, is wrong. So yes, you can have a milk allergy, and the milk can pass through breast milk. But we often think about breast milk as sort of like a hypoallergenic formula, but it certainly is possible. We certainly do see it. So just a bit more history. It's a breastfed baby. Baby had back arching, generally very unsettled, had explosive stool, was uncomfortable, had some mucus in the stool, no blood, would vomit several times a day, poor sleeper, less than 45 minutes at a time. They'd been to the GP in the past, and the health visitor had been given Gaviscon, no effect. And the mother was told by a local hospital it can't be milk allergy as baby's breastfed. So what do you do next? Do you do a specific IG to milk? Do you say to the mother to stop breastfeeding and go on to an amino acid-based formula? Do you tell them to stop breastfeeding and go to an extensively hydrolyzed milk formula? So those of you not familiar with formulas, amino acid-based formulas are the amino acids are the building blocks of proteins, and then small chains of amino acids are the extensively hydrolyzed. So it's broken down so the body can't recognize it. Or do you talk about maternal exclusion of all milk products? So I think the take-home message here is the story, there's no sort of suggestion this is a IgE-mediated allergy. So there's no role of doing an IgE test to milk. And if you did that and said it was negative, does not mean it can't be allergy. So it's really important not to use that in that setting. And I think the symptoms, the fact you've got upper and lower GI symptoms, you probably should consider the possibility, could this be milk allergy? So what you would probably do, you want to support breastfeeding as much as possible, assuming the mother wants to continue doing that, and therefore you'd say exclusion of all milk products. So the question is, how long should you exclude milk to see if there's any benefit? That 3 days, 1 week, 2 weeks, 4 weeks, or 8 weeks? So you'll probably see from my slide earlier that I said your symptoms often get better anything from 2 to 14 days. But we normally actually recommend really excluding for a total of around about 4 to 6 weeks. I'd say normally 4 weeks is sufficient in that situation. So you need to remove it for 4 weeks completely. And what you're looking for is, do symptoms get significantly better? So in this case, after 4 weeks, things were significantly better, about 80 to 90% better, a different baby. So there's a huge improvement. And that's what you often would expect to see. So what do you do then? Do you reintroduce milk, or do you say, actually, got a diagnosis and we can move on? So I think in my experience, it's really important to reintroduce milk, but I would say equally where I work in my service, that often do take shortcuts. But I think the reason it's really important is because you're very much reliant on the history. And I think irrespective of I think families want you to take it seriously. And sometimes I think the symptoms may be sort of brought out worse, but equally, I think, a lot of the time symptoms could just get better with time. So if you look at the study called the EAT study, which looked at breastfed babies, a lot of the babies had loads of symptoms when they were younger, and a lot of them get better just simply on its own. So that's why you really need to reintroduce the milk to check symptoms are getting worse again to make your diagnosis. I really would emphasize that. It's really important. So you need to, I think, manage expectations at the beginning with your patient, saying that's what you're going to do. And the way you could do it is continue that formula, or if it's on a formula, then it's easier. You can add some normal formula to that milk just to check them to get worse, so you don't have problems with then the reintroduction. If taste is an issue in breastfeeding, I think you just simply ask the mother to reintroduce milk into her diet. So case 3, a 2-year-old boy with moderate to eczema attends a party. He develops hives within 30 minutes on his hands, face and body. His eczema flares up, he develops lip swelling. There's a whole array of potential allergens as meringue, peanut butter, sandwiches, cake and hummus. So not a very allergy-friendly party. Also balloons around. So blood tests were done. IgE was 3.01 units per litre. That's positive. So should egg be excluded? Yes, no, or you want further information? So I would argue you'd say you want further information. The key thing you really want to find out is, has this child eaten egg before? And meringue considered to be like lightly cooked, so something like a runny egg. So if the child's previously eaten things like runny scrambled egg, then it's extremely unlikely to be allergy. So the key thing here from this is very much is a positive test, i.e. sensitization, which is the positive test, does not equal allergy. That's a really take-home message. So the history has to guide your allergy test. In that situation, actually, you really don't need to test sort of egg. So actually testing to egg was not done. The child's previously handled balloons, so latex is not going to be an issue. He's not had sesame or peanut butter before, so both were tested. And you have a result of 1.01 kilunits per litre to sesame, and peanut is 18.5 kilunits per litre. So just to explain that, so the higher the test is, the more likely it is to be allergy. So size does matter, higher it is. And we know with peanut, if there's more than 15 kilunits per litre, you have more than a 95% chance of being peanut allergic. So in this case, sesame is less clear. So I think really it talks about size matters in increased risk, but nothing to do with severity. I think saying that someone's got a severe allergy is the wrong terminology. Someone has a risk of a severe reaction. And if you have a peanut allergy or sesame allergy, you have a risk. So in this situation, actually, we probably needed to do a challenge to sesame to determine if they actually are allergic to sesame. Just to say, in egg allergy, the MMR vaccine and the intranasal flu vaccine are safe. With the intranasal flu vaccine, the only exception is if you had a severe anaphylaxis requiring intensive care, and that means the flu vaccine probably should be done under medical guidance. That's more because it hasn't been looked at, rather than actually definitely cause a problem. But I've never met a child who fits that category. So pretty much everyone with egg allergy can have an intranasal flu vaccine. And the Green Book is really helpful for guidance. We know 7% of children can tolerate baked egg products. So often in Nest, what we do, we try and, with dietetic advice and help, we talk about baked egg introduction with quite small amounts and build up. And that's similar with IgE-mediated milk allergy. And we know approximately 30% of children with egg allergy have a risk of peanut allergy. So in our clinic, we have the ability to do challenges, so we tend to test a peanut. The problem with that is, you get a positive test, what do you do? There is some guidance on AllergyUK about weaning advice as well. So case 4, 12-year-old reacts to apples with mild lip swelling, itchy tongue, uncomfortable throat within 2 minutes. Recently ate hazelnuts and the same reaction as apple. And now he's worried and avoiding all nuts. He has hay fever from March until July. He's previously eaten nuts and ate peanuts regularly. And sorry, it should be almonds and hazelnuts regularly. And he can also eat apple pie, and he's had cartons of apple juice with no problems. So this very much is a case of pollen food syndrome. And just to explain it to you, this is when you're allergic to birch pollen, and lots of fruits and a few of the nuts are very similar to birch pollen. So your antibodies against birch pollen bind to these foods, and that causes the reaction, which is a mild reaction, which happens very quickly, generally just in the oral pharynx. And once that is digested, the reaction stops. And so what happens is, and if it's heated up, the reaction doesn't cause a reaction because the protein's denatured. So if you look at primary nut allergy to pollen food syndrome, history of previous reactions. So in pollen food syndrome, it's very much isolated to the oral pharynx and throat. It's very rare to have a systemic reaction, so we don't tend to give them adrenaline pen. and anaphylaxis is uncommon. Whereas in primary nut allergy, it's uncommon to just have reactions in the mouth. Systemic reactions are common and anaphylaxis is common. Equally, I think about the dose. So pollen flu syndrome, you can have a reasonably high dose and that shouldn't result in a severe reaction. So if you had a small dose which just caused mild symptoms, you can't say it's not a primary nut allergy just because it's just isolated in the oral pharynx. And equally, you can have both pollen flu syndrome and a primary nut allergy as well. So it can get confusing, but things to try and differentiate, if they've reacted to raw foods, then it could be both. But often if they don't react to the cooked or roasted nuts, then it's uncommon in pollen flu syndrome, but still possible. And then reaction to fruits we talked about in pollen flu syndrome, it's common to react to raw fruits and vegetables, like carrots and apples, but cooked you don't react to it, whereas it doesn't affect primary nut allergy. And then the common nuts causing pollen flu syndrome include hazelnut, peanut, and then almond, walnut, and Brazil less commonly, but cashew and pistachio don't. So moving on to food allergy management, I think it's really important to get a clear dietetic plan. So what we offer in Leicester is we have a very much one-stop shop where we offer dietetic input to help with that. And then we have a medication plan. So we use the BSACI, emergency action plans. We prescribe the appropriate medications for school or nursery and then to carry around outside school. And we consider comorbidities, try to be holistic. So why asthma? Because if your asthma is not well controlled, you have a risk of having a more severe reaction. But you think about quality of life, so making sure we treat the eczema as well as the hay fever, as all that can impact on a child with multiple comorbidities. So when to refer, I very much think it very much depends on your competencies. And therefore, I think, and also what services are available in your area. So it's useful to know what services are available in your area. But often I'll say if I had anaphylaxis to milk or FPIES to milk, faltering growth with one or more gastrointestinal symptoms, symptoms not responding to a single elimination diet. The tests are negative and a strong history. And the reason we say that is it might require a challenge. So if you've got a really good history of having an immediate reaction on a couple of occasions, test is negative, I'd probably think they need to have a challenge. Depends on your competency, as I said, and also if they think you'd benefit from an MDT approach. But that depends on the services available. These are really helpful resources. So obviously AllergyUK got some useful resources as well, but I find the Itchy Sneezy Wheezy website, which was done by Imperial College, a really useful website for eczema as well, also how to use nose sprays and inhalers. Then we have the BSACI resources, so that's for the action plans, which again are really helpful and I think really important to help support children. And then there's also spare pens in schools. So schools are able to purchase a spare donor pen to be used in children at risk of anaphylaxis. But if they were to do that, then they probably need to have the BSACI action plan. So they go hand in hand, really. So that's very important. So just to summarize IgE-mediated allergy. So I think we've talked about the actual history is so important, that sensitization does not equal allergy, and equally that size matters and doesn't really talk about risk. It talks about risk of allergy, but not severity. Your non-Ig allergy, again, the history is important, but it's really important to completely exclude the food for 4 weeks and then you reintroduce it to make your diagnosis. So we're going to change tack slightly. I'm going to give you a case. So this is a case from that we've been given. So when Freddie was 6 months old, I gave him banana porridge that contained semi-skim milk. He usually had banana porridge but with no milk. And 2 hours later, he started to projectile vomit. And as Freddie had an older brother, I thought he might have a bug. And at this point, I didn't realize I gave him the wrong porridge. So I put him to bed after he stopped being sick. And when I woke up an hour later to check him, he was blue, unresponsive, and had a mucousy nappy. And he was also very pale. I immediately put him in the car and took him to A&E. And as soon as I brought him there, they took him straight to resus. And I immediately realized that something was very, very wrong. So this is a case of FPIES, which stands for Food Protein Induced Enterocolitis Syndrome. So it's a non-Ig mediated food allergy that typically presents in infancy with repetitive protracted vomiting that begins anything from 1 to 4 hours after food ingestion. Sometimes it can be slightly longer than that. It's my colleague Dr. Lake sort of refers to it as the anaphylaxis of non-IgE mediated allergy, but it is a relatively quick reaction. Other symptoms, often you look pale, lethargic, you may be limped and floppy, you can have diarrhea, and equally you can get dehydration requiring medical emergency treatment. There shouldn't be any cutaneous or respiratory symptoms, and it can result in hypertension, hypothermia, and mimic sepsis. So sometimes people can be, and have been reports of people having sort of operations and CT scans unnecessarily because they thought there was a surgical problem. So I was fortunate to be involved in a British Paediatric Surveillance Unit study with the Royal College of Paediatrics, and just want to thank all the team involved in that study, and the person I worked with most closely was Mish, La Jeunesse and Cherry, but the whole team has been really helpful. And what we wanted to really do in the study was to actually look at the how common FPIES was in the UK. We knew it was rare. There had been a similar study done in Australia, but nothing had been done in the UK. And so that's why we did this BPSU study to try to identify it. And that was the main driver. And the way the studies works is every month a email gets sent to every paediatrician in the UK, and they're asked to report any cases of FPIES, amongst other conditions. And if they do report a case, then what will happen is they fill out a questionnaire to give us some more data to try and determine whether it actually was indeed FPIES. So we got a whole lot of data from that, and that gave us a fair amount of information, and it's due to be published in Archives of Disease of Childhood. So it's not published just yet, but you can look at it if you're interested in that. So I'll just share some of the results with you. So the diagnosing clinician, so we had a total in the end of 98 cases. There were 204 reported cases. So that's in the whole of the UK in a 13-month period. So more than 70% of the cases were very much sort of reported by paediatric allergists or paediatricians with an interest in allergy or allergy-associated healthcare professionals. So it's very much in that sort of group. Other paediatric specialties was quite low, so we were expecting there to be a few more sort of gastroenterologists that saw cases of this, but actually that was relatively low. So the first thing to note is FPIES is rare. So in children less than 24 months in England, the reason we only could present data in England is there are so few cases in Scotland and in Ireland, was 0.006%. 0.6% per 10,000 live births. And you might say, well, why do I need to know about it? I think it's often it's a rare condition, but actually it's often people have really hard journeys with FPIES. And that's why it's important to try to identify it, because actually get appropriate management. I think they have a really tough time. So we wanted to raise the profile of FPIES. It virtually always presents in the first year of life. And what we found, the most common foods that cause FPIES are milk, soya, fish, and eggs. Those are common foods that cause allergy, but also rice is pretty common. So that's a really uncommon that you'd often think, well, rice doesn't cause allergy, and many reactions to foods were seen. It's important to note that more than 70% was just a single food trigger, and 20% were 2 foods that cause the FPIES. So it was really rare to have more than 3 foods causing FPIES reactions. And that's important when it comes to reintroduction of new foods and things like that. This just gives you sort of the food triggers. So as you can see, we can see the common food triggers. So egg, milk, soya. Relatively fish, looking at that, is actually relatively high, so 14%. And then you have a sort of peanut and tree nuts, so it's in there. Then you have some more of the uncommon things. So actually like meat, so chicken and beef and other meats. That's really uncommon for IgE or non-IgE in terms of typical sense of it. But for FPIES, it can be meats. Equally for FPIES, actually we saw typical foods that you normally think are safe, so avocado, banana, sweet potato, even norm potato. That's interesting. And then other grains such as rice and oats. Although you can get IgE mediated, actually it's uncommon. So any food can cause FPIES, and that's really important. So just because it's not a typical food, it sort of FPIES breaks the mold in that sense. I think the other thing that we found is that the study showed that there was a long delay in making a diagnosis, and thus appropriate management could not be instigated. So it's really important. So 50% of children attended an emergency department, and 47% had 3 or more reactions before a diagnosis was made. So that's another reason I want to raise awareness, because these patients had a hard journey, and therefore it's important, if you see it, you think about it. So I think if you see a child who's got repetitive vomiting approximately 1 to 4 hours after eating, think, could this be FPIES? Could it be that one case you see in your career? And what information can you give to families? So both AllergyUK and FPIES UK have got really useful information. I'd certainly refer to a pediatrician with an interest in allergy, because it's really important to help support these families to try, especially they get very worried around weaning time, and that's often when it presents, and that can cause quite a lot of difficulty. I'll just share with you a survey we did with also some through FPIES UK, and this really covered over the study period that we did the study. So we want to identify whether they were diagnosed. So we only focus on those who are diagnosed in that period to get their experiences. So during the time between the child's first reaction diagnosis, how many healthcare professionals did you see? So you can see sort of more than sort of 75% had either seen 3 or more healthcare professionals before a diagnosis was made. So that's quite a lot, I think. And so I think potentially, if we can improve that, that will make a certain improvement to the families with FPIES. And that's what we're trying to achieve. So how satisfied with your process of diagnosis for your child? So looking at people who are somewhat satisfied, a little bit satisfied in blue, not at all satisfied, you probably come to in excess, probably about 60% within that category. It's actually not particularly good. So therefore, we're not doing well for FPIES in that situation. Here's a quote from a mother from the survey: told it wasn't an allergy, and then it couldn't be milk that had caused a reaction. Suggested it was my fault for overfeeding her despite the violent vomiting and turning blue. Only recently, within the last 2 weeks, been told about FPIES by a dietitian. I'd searched the internet, no mention of it on the NHS website. I was told by my GP to just try her on another formula and see how she reacted, not taking me seriously when I said how violent her reaction was, the 2 times she had formula. The same thing from the health visitor. Try with some more milk. I asked to be referred to a dietitian. It was never suggested. Not much support is out there, sadly. My consultant is still of the belief that my daughter's allergies are not serious and that she isn't anaphylactic. Now we should be able to cope with a bit of sick and diarrhea. Just adamant we keep trying the milk and soy ladders, as we are doing my daughter a disservice and likely creating more problems in the long term. So really the take-home message is we really need to improve recognition and diagnosis of FPIES. So instigate appropriate medical advice, appropriate dietetic management, and potentially put in place the ability for appropriate acute management. So acute management is very much, if you are dehydrated, you're worried about that, you're going to try oral rehydration. Failure to that, you might need intravenous fluid, and certainly a proportion of patients did need intravenous fluid. So it's important from that point that you can present in shock. If you have vomiting, there is some evidence to try to use ondansetron to try and stop the vomiting. So it is important to get a clear management plan, but the most important thing is to instigate appropriate dietetic management. So the key thing is to really share this with your colleagues, make sure you're aware of it. And if you ever see a case like this, please feel free to discuss it with an allergy person with interest in allergy. Very happy to be contacted if you wanted to contact me, and equally via AllergyUK. So I've probably got some time for questions. Really, thank you for your attention, and I'll be staying till after the next session as well if you have further questions. Thank you. I think you're on mute, Laura.
Oh,
you're
no,
sorting now.
Can you hear me?
I can hear you now. Yeah.
Oh, apologies. Thank you for a great presentation. It was very informative. We've had quite a few questions come through about a range of things. You mentioned in your talk that although it's unusual, cow's milk protein can go through to breast milk. And the question is the same true of passage of other potential allergens via breast milk as well?
So I have to say, in my experience, the answer is yes, sometimes with soya, sometimes with egg, and sometimes with wheat. But I have to say it's uncommon. So I think it's very important to really, if you're going to try that, I think you have to be very clear in trying to remove those foods for 3 to 4 weeks, ideally 4 weeks, and then reintroduce it. Because again, you don't want to restrict the mother's diet significantly, unnecessarily. So I think, yes, it can do, but I think generally it's unusual, but it can happen.
I think I would agree, and the same in my practice as well. That's true. There's a little bit of, you've talked a little bit about IgE testing and the non-IgE about how we would diagnose that as well. Potentially, lots of people want to know, what are your thoughts on non-IgE allergy testing? Are there any reliable ones at all?
So the best test is complete removal for 4 weeks and then reintroduction. That is your test. So ultimately, that is the best test. I think the problem is if you do IgE testing, you're going to get that evidence of sensitization, and that does not equal allergy. So you're going to have, and equally, if you get a negative test, you can't say it's not allergy. So I think there are no actual tests. Your test is complete removal followed by reintroduction. And I think where people cut corners is they just remove it and they don't reintroduce it. And I think by doing that, that's probably why we probably do overdiagnose non-IgE milk allergy a little bit. Having said that, I think that's why it's really important at the onset you explain that to the family why you're doing that. And I often use that case of that EAT study done by Michael Perkins, where if you look at the actual symptoms, a lot of babies in the first few months of life have lots of symptoms: vomiting, colic, loose stool, and that often gets better with time. So I think you need to, and so therefore, has this got better with time, or is it due to removal of the allergen?
Lovely, thank you. This question reflects quite a lot of calls that we get through to Allergy UK. So potentially a parent that's got a nut allergy, or a sibling that's got a nut allergy, or there's a lot of concern over allergy. But a child with eczema and egg allergy then has a positive skin prick test, 3 millimeters to peanut, but never eaten nuts, so never had an allergic reaction to nuts. Would you reintroduce nuts for a child under 1 year in this situation?
So it's just unclear. So you have a skin test of 3 millimeters,
To
and we're
peanuts,
saying,
never eaten
do you
it.
do home introduction?
Yes, exactly. Would you introduce it or not? I'm sure it depends on the situation, but I'll leave that to you.
So I have to say, from my experience, what we do in Leicester, if it's 0 and 1 millimeter, we'll say to introduce that at home. And if it's more than that, we are doing challenges in that situation, and we try to do challenges relatively quickly. Now, I suppose, in a sense, what do you do if it's 3 millimeters? So previously, we'd say 3 millimeters is a positive test. I think, in a sense, the risk of actually reacting is probably around about 10% based on, I think, the LEAP study. And so I think one can be pragmatic. You can talk to the families and gauge what they want to do. So you could suggest trying a very small amount. So literally, I often draw pictures. So literally a pinhead amount of peanut butter. And if that's okay, you can go to a bit more. But I think it depends on where you stand with that, because I think you have to talk it through the families and you make a joint decision with that, and also how comfortable you feel with that. So that it has opened a can of worms. I don't think we have a clear way of doing this. I'm very lucky that we got access to challenges. I think if it's certainly going above 3 millimeters, I think you probably do need to do a challenge. I can't give you cutoffs for IgE because I don't do much IgE testing. So we do mainly skin tests in our clinic, and we rely on skin prick tests. So I think it's joint decision making with the family, how they feel. But I think that is a problem, and we haven't got a solution across the UK on how to address this.
Perfect. There's a little bit more. So the next one is a 5-year-old with a dairy and nut allergy. Is there anything that can be done to speed up introduction of dairy other than doing just repeat skin prick tests every year?
So I have to say, so I assume you're talking about an IgE-mediated milk allergy. So I have to say, what we do in Leicester is we very much start a baked milk introduction, and we start off with a crumb of a malted milk biscuit. So some places do challenges for IgE milk allergy, and they will go to quite a big dose of milk. We found in Leicester by getting a very slow introduction, so a small amount and building up, actually works extremely well. And if you're interested, I'd refer you to the BSACI guidelines on milk allergy is one resource. And then the other resources, I'm not sure it has been will be released soon. I think AllergyUK are going to do sort of some milestones on milk allergy, which also have a milk ladder. So this is very much to help with IgE-mediated allergy. I just say that there is a milk ladder for non-IgE allergy. We use the same one for IgE and non-IgE. And that's I've forgotten the name. What's that, Laura? That's the
IMAP one.
Yeah, that's the IMAP. I'd urge you not to use IMAP for IgE-mediated allergy. So I think the ladder is really important, and I'd encourage you to do that because we know 70% of children can tolerate baked milk. And by getting out in regularly, you're making a huge difference to these families. So look out for the AllergyUK milestones, and then refer to the BSACI guideline on milk allergy.
Perfect, thank you. So just moving on to FPIES, I think it's really important to get that information out about FPIES. In my experience, it's very poorly understood by healthcare professionals. So your survey was very interesting. There's a question which may be from your survey or your own experience. What's the youngest age that FPIES can present? So can it be presented in as young as a neonate at all?
So the answer is yes, it can do. So I think in a sense it can present very early on. Just to also think there's also a concept of chronic FPIES, and there's huge debate about chronic FPIES. I think a lot of us in the UK sort of aren't great believers of chronic FPIES. We believe in an acute FPIES. So that's when you have profuse vomiting quickly within 1 to 4 hours after eating the food. So yes, it can occur in infancy anytime, and most commonly in the first 9 months of life.
Yeah, absolutely. You talked a little bit about the management of it. Someone has asked, would the management ever involve antihistamines and adrenaline at all in the treatment of FPIES, so an acute episode?
Definitely not. So there's no evidence for that. Actually, we'd recommend not using those.
Okay, lovely. I think we've covered most of the questions that we want to do. Most of them were linked around kind of testing, and I think you covered it quite well in your presentation of how to move forward with that. So the take-home messages really from a FPIES point of view is to recognise the signs. I feel the same as you, that really that's very difficult and lots of people are not seeing that. I don't know, would you agree that in your area as well that it's just missed if there is a problem?
I mean, I think the biggest problem is under recognition. So if you just, I think take families, what they say seriously, just think in the back of your head, could this be FPIES? And I think if you think that, then it might allow you to ask a few more questions to probably guide that. And then hopefully it'll give you, if you get the diagnosis, number one, you'll be happy about that and you'll make a huge difference to that family.
Just one last question, going back to the allergy clinic scenario, and I get asked this question all the time. So I think it's probably come from a GP. So diagnosed a non-IgE mediated cow's milk protein allergy, followed protocol to do that, then for whatever reason gone through the allergy clinic experience, had negative skin prick tests and been told not allergy, or that's the parental perception certainly, and then everyone's confused about what to do in that situation. So I think it's the misconception with what the allergy tests mean, but I'll hand it over to you.
Yeah, I also think, I think sometimes allergy tests are used incorrectly also in secondary care. That's one thing. I think the other thing sometimes is there's an expectation from families that they want to have allergy tests. They've come to the allergy clinic to have an allergy test. So often in my practice, I will say to people with a non-IgE history, I don't need to do allergy tests because the test is complete removal for our reintroduction. and they still want to have allergy tests. So often I will do allergy tests, but explain to them it's not going to change my management, but I don't have that conflict, because in the past it's caused conflict. I don't think it's worth it, but I make it very clear before the test it's not going to be helpful. But I think that question is a good question. I think the key thing comes from your history. But I think when we have allergy tests, we will offer it if there's anxiety there. But equally, I'll make it clear beforehand. I think you can do the same as a GP. I would say in that case where you think it's possibly non-IG allergy, I would say what you could do is do your diagnostic test of complete removal followed by reintroduction. And also you could then get dietetic input. The other thing to mention with allergy tests, a lot of people go for alternative testing, so IgG testing, kinesiology, and private testing. They are non-validated tests. I would certainly not recommend them. There is no blood test or test for non-IG allergy apart from complete removal followed by reintroduction.
Perfect. Thank you so much for your time today, Gary. Hopefully
Pleasure.
we'll see you after the next session. So we really appreciate your help.
Thank you very much. Thank you, everyone.
So our next speaker today is Lydia Collins-Hussey. She's also works at AllergyUK, but is a paediatric dietitian. She's got a very keen interest in milk allergy. So I'm going to hand over to Lydia to continue.
Thanks, Laura, for the introduction. Yep, I'm here to talk about the dietary management of milk allergy and also food protein-induced enterocolitis syndrome, FPIES, as Gary's already mentioned today. So the presentation I've split into... Oh, can you see my slides? It's not moving.
Laura, Lydia, they're not clicking through.
Yeah, they're not, are they? What I'll do is I'll reshare again. Sorry about this. We will try again.
Don't worry. Are they clicking through now?
No.
Is your cursor?
I'll just come out again.
Lydia, I have your slides on my screen if you'd like me to share for you.
Yeah, I'll try one more time. It's just I've got my notes on as well, so they're a good prompt, that's all. So I'll try again because it worked fine the last time, doesn't it? So I'll try. What I'll do is I'll just reload my slides up. See, I don't know why it's... I do apologise. I don't know why it's not working. I think it's moved then. Hang on. See if it... Yeah, we're ready to go.
Well done, Lydia.
Minor panic over. Anyway, hi, everybody. My name's Lydia Collins-Hussey. I'm a paediatric allergy dietitian. I'm also the clinical dietetic advisor at AllergyUK, and thank you, Laura, for that introduction. So I'm just going to talk this morning about the dietary management of milk allergy and FPIES, as Gary has already referred to. So the presentation is split into two parts. We're going to look at the dietitian's role in allergy, also just touch on briefly guidelines in milk allergy, but mainly looking at the management of a breastfed infant or a combi or formula-fed infant. We're then going to look at the nutrients in cow's milk and how that impacts baby's diet, as well as some practical tips on food labelling and when we would use alternative milks, the plant-based milks. Then in regards to FPIES, we're going to look at the main triggers as well as complementary feeding. And then I have a case study to touch on towards the end. Oh no, this is not ideal. It's not letting me move on. Oh, there we go. There just seems to be a delay. Apologies. Okay, the role of the dietitian. So the dietitian is fundamental in food allergy. We're involved in the diagnosis, the nutritional management, the nutritional assessment, management, and also tolerance. So we're going to focus mainly around the management today, so breastfeeding, hypoallergenic formulas, and alternative milks. Dietitians are based in a variety of settings. So I work mainly in the community, in primary care, but they're also based in secondary and tertiary centres, as well as private settings as well. So in regards to guidelines, there's many out there, and it can be really confusing for healthcare professionals. And in the last decade, so many guidelines have come out in relation to cow's milk protein allergy. So we've got the World Health Organization guidelines, the DRACMA guidelines. We've also got European guidelines, ESPGHAN. We've got the BSACI guidelines that Gary touched on, and we've got NICE, as well as IMAP, which is International Managing Allergy in Primary Care. So this guideline overload is quite overwhelming for healthcare professionals, but I will go through some of these guidelines throughout the presentation, or certainly will refer to them. So let's start with the management of breastfeeding. We know it is less common in our breastfed babies than formula-fed babies, but it does happen. And around 0.5 to 1% of exclusively breast babies show reactions, and about 2 to 7.5% in our formula-fed babies. So small amounts of allergen can be detected in mum's milk, but we want to advise, if we're excluding a maternal milk-free diet, we want to actively support that continuation of breastfeeding. And so ideally a referral to a dietitian is needed to support that through that exclusion, that reintroduction, but also that nutritional adequacy. So we usually advise a 2 to 4 week exclusion. And as Gary touched on as well, I more likely will go to the 4 weeks, and then we would reintroduce back into the diet. And that reintroduction is usually over the course of 1 week. And if symptoms start to come back within 2 or 3 days, then that confirms the diagnosis. And we usually then would advise a good 6-month exclusion. And then later down the line, we would do a milk ladder to see what tolerance. So with breastfeeding, we know that there's higher requirements anyway. So for certain nutrients, so for instance, calcium, it's 1,250 milligrams a day. And the next slide, I will go into what that looks like on a day-to-day basis. Also, vitamin D helps with the absorption of calcium. And another nutrient that has become or been exposed a lot more in the allergy world, as it were, is iodine. And especially if mum is vegan or following a more plant-based lifestyle, then it's quite hard to obtain iodine sources when they're mainly from fish, milk, and egg. In terms of baby, advice is we follow public health guidelines in relation to a vitamin D supplement. And if symptoms are persisting, we may need to consider other food allergens, but it really does depend. So for instance, we see cross-reactivity with soya. So if there's a lot of gut symptoms, we may exclude that out of the diet, but we'd still do that process of elimination, and we'd want to reintroduce that back into the diet to confirm or exclude that diagnosis, because this can become very restrictive for both mum and baby. Also, we may consider egg, like Gary mentioned earlier, especially if we've got in our eczema babies as well. So what does 1,250 milligrams of calcium look like? Well, this is just on a daily basis. As you can see, there's lots of different foods here. A lot of them are fortified here, but not all cereals will be fortified with calcium. Not all alternative products, especially organic, will be fortified. So you can see it's quite hard to achieve this on a daily basis. So we often would advise a breastfeeding supplement alongside this. So usually a lot of the breastfeeding supplements will have around 700 milligrams a day in them, and then we would use the diet to top up that. But in some cases, we may need a higher supplement as well, nearer to 1,000 milligrams, which again can be obtained in local supermarkets or chemists for a few pounds. Interestingly, a lot of the pre-pregnancy vitamins, I find a lot of parents will stay on them. There's only 120 milligrams in them. So that's a lot lower than the breastfeeding ones and the regular ones that you can obtain. So it's really important to be checking that the patient is on, or mum is on, the right dose. Sorry, my slide hasn't gone on to the next one. It's like crashed.
Lydia, let me pull up the slides for you on my system, okay?
Thank you.
There you go.
Lovely. So this slide is in relation to hypoallergenic formula. So if baby is combi fed or formula fed, then we would look to trial a hypoallergenic formula. So here you can see we've got the whole milk protein. So this is intact milk protein. So this would be your first formulas, for instance. Or sometimes we anti-reflux formula will have whole milk protein as well as lactose-free formula as well. So lactose is to do with the sugar in milk and not the milk protein. So that again would not be suitable. We then have partially hydrolyzed formula. So this is where the protein is broken down slightly. And these would include formulas like your colic and constipation, or often referred to as comfort formulas as well. And again, this would be suitable. Then we have our extensively hydrolyzed formula. So this is where the protein is being broken down even further, usually based on casein and whey. And there's lots of different formulas out there, which I'll go into in a moment for the management. And then we have amino acid formulas, which is the building blocks to formula. And again, there's many different ones that we have, but traditionally, from the guidance, we would use an extensively hydrolyzed formula as our first line, and then we have amino acid formulas, and these tend to be used first line if there's anaphylaxis, faltering growth, or in conditions such as esophagitis, or if there's severe eczema or multiple allergy. Next slide, please. So hyperallergenic formula, this can depend, it's bitter in taste, and quite often we will see formula refusal as well. So often we may need to titrate the formulas or mix them. If baby's combi fed, that would be with breast milk, express milk, or we would titrate that with a regular formula. So it might be that we'd introduce just 1 ounce of a regular formula mixed with 4 ounces 1 ounce of the hypoallergenic formula mixed with 4 ounces of the regular formula. So the difference in taste is due to the protein, the degree of hydrolyzation, the presence or absence of lactose. So common side effects that we see is a reduced intake, but as baby starts to feel better, they will start to take, or usually will start to take more. We often will see another side effect of green or darker looking stools, and they often smell quite different as well. And it's important to note that the formulas continue to change. So we see there's emerging evidence around the use of probiotics and symbiotics in these formulas. So we're starting now to see these being used in relation to tolerance and decreasing atopy as well. Next slide, please. So in regards to the hypoallergenic formulas, these are the main ones that are used in the management of milk allergy. So our extensively hydrolyzed formulas would be our first line, and then our amino acids tend to be second line, except as I've mentioned, if it's anaphylaxis or if there's faltering growth. They do vary, for instance, in the protein that's being used in the extensively hydrolyzed formulas, such as whey or casein. They contain probiotics, prebiotics, and you can see there's some follow-on formulas there as well. And that does tend to be more of a marketing ploy. The follow-ons do have a little bit more iron and calcium in them, but in terms of other micronutrients, they are reduced to allow for solid intake as well. They range in cost, so our extensively hydrolyzed formulas can be from around £9.50 up to £13 a tin, and our amino acids tend to be 2.5 times more. And when a child under 6 months is on, or fully formula-fed child, on 12 tins a month, that is a substantial cost to the NHS. Thank you. Next slide. So often we'll get questions around soya formula. So there is only one available currently. We do know that there's quite high cross-reactivity with our non-IgE babies. So quite often they will react. So studies have said up to 60 to 64%, whereas our non-IgE, that's a lot lower, around 10% or so. We would usually advise, we wouldn't usually advise it as a first line, but it can be used over 6 months if there isn't a soya allergy or if the hypoallergenic formula isn't being taken, because quite often these formulas tend to be, or soya formula does tend to be slightly more palatable in comparison to the hypoallergenic formula. So complementary feeding. So just moving on to introduction of solids. So usually we would introduce solids at around 6 months, so 26 weeks, but not before 17 weeks, so 4 months or so. And this is a really daunting time for parents without a diagnosis of milk allergy or any allergy. And yeah, it can be very overwhelming. So it's about providing support for the parent. So that may be through resources or signposting to like AllergyUK. The BDA have some really useful resources, as well as patient webinars. But it's also ensuring that patient is ready to wean, or baby is ready to wean as well, so able to support their head, got good hand-eye coordination, able to swallow that reflux, that gag reflux is gone back, and able to sit up properly as well. So what do we need to be looking out for? So these are our obvious sources. So we've got milk, yogurt, butter, and ghee. And then we've got our hidden sources such as casein, whey, lactoglobin, lactoalbumin. So we really need to be talking patients through what the obvious sources, because it is a minefield when we're trying to look out on labels. So we'll see it in common products like baby cereals, but we'll see it in sauces, potato products, lots of different products that you wouldn't expect. And there are other unexpected items that you would see it in, for instance, soaps and shampoos and medications as well. So I like this slide because it just highlights this product pretty much is identical, other than one contains milk, so the instant custard, and then we've got an original custard powder, which is based on maize starch. And again, it just highlights that for parents or carers, it really is a minefield reading labels. The 14 main allergens, the guidance changed back in 2014 for pre-packed foods like this. So the parents should be referring to the ingredients list. So those foods such as milk would be in bold or underlined on the back of the packet. But labelling can change all the time, so that it could be the packaging, for instance, or says new improved recipe. So it's really important that that patient checks the label every time. If you take anything from today, it's making sure they check everything every time, because like I say, it changes all the time. So what about introducing other allergens into the diet? So I get asked a lot about this in clinic. So the other allergens would be eggs, soya, peanuts, fish, seafood, tree nuts, wheat. And there has been some recent guidance come out from IACI, the European Academy of Allergy and Immunology. They brought out a paper regarding preventing food allergy. We used to say no egg, no peanuts until 2 or 3 years of age, but we actually know that that was helping to cause allergy. And now there's been evidence, as Gary touched on, from the EAT study and the LEAP study, that actually early introduction can help prevent allergies in some of our patients. So the advice now in our high-risk babies is to introduce early on, from 4 months, if developmentally ready, egg first and then peanut. And then for a low-risk baby, it would be as usual from 6 months of age to introduce these before the first year as well. Mm-hmm. So what key nutrients are in cow's milk? There are lots of different nutrients. This is just a few of the key nutrients. So we're looking at calcium, we're looking at energy and protein, B12, iodine that we touched on earlier, as well as B2. And it's really important about replacing these in the diet. So whether that's through alternative foods or supplements or the milks, as I'll go on to in the next slide. So there are an abundance of alternative milks that have come out in the last couple of years, especially with the drive with veganism. There are a lot more, certainly more than when I first came into allergy. And you can see that they're based on a variety of different products or ingredients. So we've got soya, coconut, almond, hazelnut. Recently, we've had potato that's just come out, and that's been mixed with pea in the last kind of week or so. But we need to be careful that some of these milks are being mixed with other ingredients. So for those with multiple allergies, it can be really tricky. But for our babies, we would only use these in cooking from 6 months. They can be used as a drink from 12 months of age, but that is really under the guidance of a dietitian to ensure growth, nutritional adequacy, that there isn't any restricted diet. So often allergy dietitians tend to move around somewhere between 12 to 18 months, but the NICE guidance says up until 2 years. So it's really dependent on an individual basis, because they really do vary in terms of nutritional composition. Some are sweetened, unsweetened, some are flavoured, some are fortified. So they do really vary, as I'll show in the next slide. Oh no, you're not having trouble too with the slides. Okay, so here we are. This is just a sample of different products out there. So you can see there's cow's milk on the top, so full fat cow's milk that we would be giving usually from 12 months of age in a non-allergic child. So this is 66 calories per 100 mils. And you can see they varies considerably as you go down, and that a lot of the tree nuts and coconut milks are a lot lower. So we're aiming usually somewhere around 45 to 50 calories per 100 mils, ideally, as an appropriate milk source. And then in terms of protein, again, it's very high in cow's milk, 3.5, and we're looking for around 2 to 3 grams per 100 mils. And the oat milks, your nut milks, they're so much lower. But if we can replace them in the diet elsewhere or with other foods, it's all about the individual. So it might be that we do use an oat milk, for instance, because baby is reacting to milk, soya and pea, for instance. So it really depends on the individual and how they're doing. In regards to calcium and iodine, then the majority of these are fortified apart from the oat milk, and this is because this one is organic. So we just need to be careful that not our organic products will be fortified. And you can see that there is a considerable difference in prices here. So when a child, usually say somewhere between 300-400 mils after 12 months of age, a day roughly, so that can mount up, especially if having on cereal. They may be having 3 litres a week, so that's a considerable impact on the weekly diet, on the weekly shop as well. But it's just to be aware that there is no one perfect milk out there. As I've mentioned, it's on an individual basis, and some children we may not even wean off. Other children will wean themselves off milk, we're having to substitute through the diet. So it really does depend. So in regards to tolerance, most babies will outgrow their milk allergy by school years. But I just wanted to touch on this around tolerance, mainly in relation to the milk ladder. Gary has already mentioned that it's mainly used in non-IG mediated. And if you type in the milk ladder into Google, you'll see the IMAP and MAP guideline. And these are based on a 6-step and 12-step. And we normally start to introduce this ladder for our non-IGEs between 9 to 12 months of age. And then we would introduce slowly into the diet baked foods in a wheat matrix first, such as a biscuit or cake, and then build to cooked sauces, and then pure sauces such as yogurt, cheese and milk itself. That really is a whistle-stop tour of the milk ladder there. But in terms of IgE, as Gary touched on as well, it's normally under the supervision of a clinician within secondary care if they've been advised that. And again, it's small amounts, like a crumb or so. Okay, so just moving on to the dietary management of FPIEs then. So I really like this quote from Karina Venter. She's a well-known dietitian within the field, and it's just to highlight that, yes, we've got our common triggers, but actually a lot of children, as highlighted in Gary's study, react to low allergenic foods or perceived low allergenic foods. And this can be particularly hard to manage when they're not listed as the 14 main allergens. So when we're shopping and label reading, it can be a really challenging time. So here are the main triggers by continent here. So this is a paper from Infotel et al. And as you can see, there's geographical variation across the globe. And this is based on different feeding practices. So you can see in America, their main sources are milk or soya and wheat, whereas in Europe, it's milk, fish, and eggs. So Grosh et al. Brought out a study recently, a dietitian, highlighting some of these triggers, being milk, egg, soya, fish, and grains. And obviously we've got that new data as well from the UK that we're seeing other triggers. That fruit and vegetables is certainly high that we're seeing, so avocado, banana as well. I'm only going to touch on chronic FPIES, as it's not well recognised. It occurs early in infancy. Symptoms include intermittent vomiting or diarrhea, mucus in stool, faltering growth. And then 99% from Grosh et al. Study, they highlighted that they are either triggered by cow's milk or soya-based formulas. So very few, 1% of breastfed babies, and within 1 to 4 weeks of introducing either a milk or soya-based formula. Infants also with cow's milk or soya FPIES, they found that they develop at a young age are more likely to develop FPIES to solid foods. And in regards to formula, what one would we use if it's milk FPIES? Well, the guidelines really vary in relation to this, but the majority say an extensively hydrolyzed formula. But this will really depend on the baby, or if there's faltering growth, then we'd move to an amino acid formula. So what about complementary feeding? Well, the majority will happen in relation to acute FPIES on the introduction of solids. And we know from the Grosh et al. Study, 51% react on first exposure, 14% on second exposure, and 11% on third exposure. There's very little guidance on what's best and how, or what is the best approach to introducing solids into the diet. It's a very daunting time, and the advice is to introduce one food at a time over 4 days. But as infants starts to increase their variety, to start to include more. But we would advise doing kind of food and symptom diaries and in regards to what foods have been introduced. But we've certainly introduced just small amounts initially, so 1/4 of a teaspoon, and then build up. We then choose those well-cooked options where possible that have been cooked or baked. They're more likely to be tolerated. And then we would encourage foods to enhance kind of that development. So even if they're only managing one food, we'd make sure that was like crunchy or lumpy or pureed or finger food, to make sure that we're meeting those milestones. Grains are often avoided, but they have a really high nutrient value. For instance, they are high in energy, they've got a lot of fibre, B vitamins, iron, calcium if fortified. So an individual approach is really needed when it comes to FPIES and introducing solids. This is again from the Grosh et al. Study. I'm just going to refer to the right-hand side here, and it's a really good starting point, to be honest. There's still not many foods on the resource, but it certainly gives us some to be working with. And you can see it's based on 3 different approaches, so a lower risk, a moderate risk, and a high risk. So you can see a lot of the low risks around meat in particular, so lamb and beef, and other proteins and grains that we can introduce into the diet. The Food Allergy Specialist Group, part of the BDA, they also have a draft version that is still being worked on at the moment. And this is a similar process in that it will work on uncommon triggers to start with, and then move to more common triggers. So again, it's just a really good starting point and something to guide parents through, because there isn't a lot of resources out there to support them currently. And that's just because of evidence available as well. So in regards to preventing deficiency, there's limited data on specific micronutrient deficiencies in FPIES, but it is perceived that it is the same as that in food allergy. So we're looking at vitamin A, calcium, D, iron, zinc as well. But always we would rely on a dietary assessment, so a referral to a dietitian. And we would follow usual public health guidelines in relation to vitamins A, C, and D, and supplementation for infants. We can advise also on fortified foods, although a lot of these foods are cereal based, so quite often we can't introduce those first. And then we want to avoid over supplementation and to monitor frequently, whether that's through diaries or blood markers. And growth monitoring as well. So quality of life, the impact of food allergy has been linked to that of chronic diseases, and Roseanne Mayer brought out this study in 2014. She's a well-known dietitian in the field, and she reported feeding difficulties in 30 to 40% of children with food protein-induced GI allergies. And this corresponded with the more foods that were being excluded. It just highlights that this has a massive impact, not just for the child, but also the family and feeding difficulties. So it's trying to address these feeding difficulties early. And if babies being seen in more of the tertiary centres, then they'll have access to an MDT or where there is psychological impact. And I know that we're talking about this later today, but there's certainly an unmet need when it comes to psychological services and helping in regards to quality of life. So there is some support out there. There's international and national support. So we've got FPIES UK, the FPIES Foundation and the International FPIES Association. We've also got AllergyUK as well as another resource. Social media is becoming really popular. So we have Facebook and Instagram, Twitter. There's definitely allergy communities on there. And FPIES UK, they actually set up a Facebook group to support patients, recipe ideas, and just in general, more awareness around FPIES. So just going to talk to you a little bit about baby T. He came into my clinic, so it's a community clinic, and had a referral from a GP. So we had reflux, unsettled, he was really irritable, colicky, had mucus stools. Mum was exclusively breastfeeding and had started to follow a milk-free diet, and the GP advised a milk challenge. So he reacted to the milk challenge. However, at 5 months of age, he had some baby porridge. They were plain oats made with express breast milk. Within 1 to 2 hours, he was profusely vomiting, and he was then admitted to A&E, where he continued to vomit, retch. He went pale, cold, very unresponsive, and limp. In hospital, he required IV fluids. He was recorded to have a low temperature, and he was diagnosed in hospital with gastroenteritis and discharged. Within 24 hours, he was back to his normal self. So as part of our allergy focus history, I said to Mum that I think we're querying FPIES here, and that I would like an opinion from a consultant with an interest in allergy as well. So just to go through baby T's symptoms in relation to NOAC's guidance, we can see that he vomited, his behaviour changed, he decreased activity and lethargy, he went pale, he required IV fluids, but he also had some of the other symptoms as well. He did have some diarrhoea later on, and he was hospitalised, although I had no access to his blood, so I was unaware of his bloods. Focke et al. Also brought out a study in regards to differential diagnoses in FPIES, and there's a lot longer list in the paper, but it just highlights that it is a particularly difficult diagnosis. As you can see with baby T, he got diagnosed with gastroenteritis, and this is quite classic that I've seen in A&E, and also sepsis quite often as well. So in regards to our assessment, he was thriving, weight and height, both were tracking 91st to 98th centile. He did have limited variety. Mum had stopped introducing solids after the oat reaction, as she was really worried. She was also really worried that he was reacting in her diet because he was very irritable and unsettled, and those symptoms started to persist. So Mum started to exclude other foods out of her diet, like fish, egg, and she'd read up about FPIES, so she started taking chicken, potato out of her diet, which was very, very restrictive. She wanted to continue breastfeeding, but also was thinking about starting combination feeding, so we discussed around an extensively hydrolyzed formula. which he didn't accept, and mum was happy to go back to breastfeeding. And mum was taking a multivitamin, but we also discussed around kind of minerals, as well as baby T taking his vitamin D as well. And we also again talked around a multivitamin and mineral supplement for him, as mum was starting introduction of solids, and we're worried in regards to iron intake, as well as baby stools start to reduce. So requested an onward referral to a paediatrician with interest in allergy. So over the next few weeks, mum had introduced some veggies and fruit with no issues, which was great. We discussed the iron-rich foods, but there were some foods that mum was reluctant to introduce. So we'd managed to get lamb into his diet. We managed to get some fruit and vegetables. We also had managed a quinoa porridge that mum was using a coconut-based milk that was full of extra vitamins and minerals. So we were managing to get some other vitamins and minerals into his diet other than through supplementation and breast milk. He was still doing well growth-wise. He was a really good feeder in regards to breastfeeding. Then he had another A&E admission. He was profusely vomiting. He had 1 hour after ingesting a rusk, he went very pale, exactly the same as what happened with the oat reaction. And it was assumed that it was a likely reaction to wheat, as mum offered the rusk with breast milk, and she was still following milk-free diet. At this point, he had not been seen by the paediatrician yet. So he was then seen in an allergy clinic. He was diagnosed with oat and wheat FPIEs. The allergy team also conducted skin prick tests to rule out IgE and things. So he had rye, barley, wheat, oat, milk, lots of different skin prick tests, and some of them they weren't sure if they were positive. I didn't have access to his results at this point, so it was from mum messaging me. And then he's now due to have hospital oral food challenges to widen his diet, but he's not under me, unfortunately. I'm based in the community, and he's now involved in an MDT tertiary allergy clinic, so our care ended at this point. So the key messages in regards to FPIEs, it isn't well recognised, and delays in diagnoses happen. It's really important to not manage alone and refer to a paediatrician who has an interest in allergy, although we do see delays with that, as seen in baby T's case. Ideally refer to a dietitian. Complementary feeding can be such a daunting time without that diagnosis of FPIEs. Parents and carers need a lot of advice and support, and it can be a really confusing time, complementary feeding. So with baby T, for instance, he also had teething, he had sickness, so it was really difficult sometimes to decipher if it was allergy or if it wasn't as well. And thank you very much for listening. Sorry about all the slide issues at the beginning.
Thank you, Lydia. Don't worry about the tech problems. We know it's live and these things happen, but it was a really informative talk. So thank you very much.
You're welcome.
If anyone's got any urgent questions, please put them through Slido now, and we'll try and answer them in the next few minutes. I've got one, and we've got one come through. So the first one is, what is your advice on introducing allergenic foods for babies with IgE-mediated milk allergy? Is this different to those with non-IgE?
So we still, so the BSACI and the BDA food allergy specialist group have the practical guidance around this. So you can, if you just Google preventing allergy for your baby, it will come up, that guidance, and it just goes through, it's got algorithms in there to talk baby through, so that it will talk about the high risk who have IgE or have a food allergy already, or those that have moderate to severe eczema. And yes, we would introduce that into baby's diet, but it might be they're under consultant already, so you would liaise with your allergy team or whoever's involved as well. But for our low risk babies, as I've mentioned, we would still introduce those allergens from 6 months, once a weaning's established and got those first foods into the diet. Perfect, thank you very much. There's a couple of questions on how do you distinguish between cow's milk protein allergy, so immediate IgE mediated allergy, and FPIEs. How do we decide Yeah, I think this is what Gary was touching on with the chronic FPIs. We still don't know, and as you said, not even sure this is a diagnosis, but I wanted to touch on it because I think it's important that sometimes it is unrecognised, and it is difficult to know, but acute we would know very quickly, in the sense of it's that 1 to 4 hours projectile vomiting that we would see. It's very clear in that respect. Gary, have you got anything to add in regards?
I'd probably just say, so I mean, in FPIs there should be no cutaneous symptoms. So normally with milk allergy, IgE mediated, you have a clear sort of hives or lip swelling. In FPIs you don't get that. So it's unusual to have with milk just quick vomiting. So I think it's relatively easy to differentiate from a history. I think the exception to that is egg. Sometimes there's egg reactions just present with this vomiting. So that's why you might be doing IgE testing. But remember, FPIs is profuse vomiting. It's just not 1 or 2 vomiting, 1 or 2 episodes of vomiting. It's quite severe vomiting. And vomiting is a definite feature of FPIs. So you can't have FPIs without vomiting. And I know Lydia mentioned chronic FPIs. I think you'll read up about it. I still think, I mean, ultimately what chronic FPIs tends to suggest is when what they say is you've got lots of what we call non-IgE mediated symptoms, which are quite significant. And then when you stop the milk and you reintroduce it, you have an acute FPIs reaction. So I tend to prefer using the terms non-IgE milk allergy when they've got lots of symptoms. And if they have an FPIs reaction, I'll say they have an acute FPIs to milk.
Perfect. Well described. That's great. I think one of the things that I worry about is these patients who may think their child has FPIs, but getting access to services in a timely way. So they may have gone into A&E and had treatment for dehydration, for example, but then they get to the weaning point. That's very difficult. Any advice for kind of GPs, health visitors, how to manage that situation? Because although we say refer, we all know the pitfalls of that at the moment.
Yeah.
I don't know, easy answer, possibly call AllergyUK.
You could do that. That wasn't the answer, but just generally, like, it's very difficult, isn't it?
It is really difficult. I mean, I think it's also hard. I think, just also emphasize, I think sort of both Laura and Lydia are dietitians, and what I think makes a really good allergy service to not so good allergy service is having dietetic input. So really, I can't emphasize enough, knowing your local service, do they have dietetic input? Equally, possibly knowing some of the community dietitians, do they have some allergy experience? Because actually, it's so important to have dietitians, because that really does help families have an adequate diet for their child, so they're less anxious and giving alternatives. So I think that's so important. I think the other thing is also from a diet point of view, I think there should be, from the British Dietetic Association, there should be some guidance happening for FPIs as well, hopefully in the next few months. So I think, and all dietitians, I think, have access to the BDA. We don't as doctors, but only dietitians do.
And there's lots of resources in relation to allergy through the BDA, the Food Allergy Specialist Group. Not so much on FPIs, but we are growing that, and as you see in the draft as well, in regards to the complementary feeding.
No, absolutely. And I think that would be great moving forward, to make these resources more accessible to everyone is a good thing. Okay, there's just some questions, and you're both from different perspectives, so it'll be interesting in your answers. But when introducing egg and peanuts in high-risk children, so not had allergic reactions to them, but high risk, presumably through other reactions to foods or eczema, how do we advise to introduce these?
So, okay, yeah.
In what quantities, for example?
Yeah, I think personally with egg rarely results in severe reactions. So I think the first thing is, it depends how you want to do it. So I think in a high-risk group, I'd often talk about getting baked egg products in first, and you go with small amounts. So we've always taken the approach of small amounts. So I'm just giving examples. Let's say a small of Yorkshire pudding, which has been cooked. You don't give a whole amount, give a small amount. That's okay. Then in the future, you can give a bit more. So with batter on things like fish fingers or things like that, a small amount, and then you can increase it. And I think that's where I would do it for egg. I'm not sure if Lydia disagrees. I think for peanut, the whole difficulty depends on what access you have to services, whether you've tested and how families feel. Because I think in a family who's really, really anxious, they're not going to introduce peanut, even if you ask them to. So I think you have to have a conversation with the family. Do you want to introduce it? Yes, there is a low risk, but I think the risk of having a severe reaction, I think again is low, and that data is relatively clear. So I think giving a small amount, and I really mean it, sort of very anxious, you say a pinhead amount, and if that's a tolerator, you double that dose, and you do it slowly and sensibly. They have an IG-mediated allergy, they know how to use antihistamines. I think it's extremely unlikely to have a severe reaction. If they're really anxious and they don't want to do it, then I think the other thing is, if you're in the community, what you could do is you could do an IgE test to peanut. If that was negative, then you can confidently say it's not peanut allergy, get it in, if you've done an IgE test anyway. And if it's positive, then the only option might be to refer to get seen in a clinic, and then they have access to a challenge. So I think it's trying to modify, know what you have locally and what the options are. It's quite hard to give a sort of a one size fits all.
I agree. I would always start small. And I think, and also a really important point is that once it's in the diet, it's really important to then keep it in the diet as well, because that quite often doesn't happen. It's like, oh, it's only been tolerated once or twice. And actually, no, we need it to be regularly in the diet. So there's the SAG and the BSCCI. They advise initially like 1 egg a week, but actually in practicality, like of that, it can be quite difficult when baby's not had solids anyway to start with. So always start small anyway. But yeah.
Perfect. Thank you so much for both your input. It's been a very interesting topic this morning, and I'm sure very well received. We're going to take a short break now. So between 11 and 11:15, we're going to take a break, and we'd ask you to be back by 11:15. Okay, thank you. Welcome back after a short break. I hope you've had a few minutes to stretch your legs. We're going to move quickly on to present our next talk. We have the pleasure of having Dr. Vibha Sharma here today. She's a consultant paediatric allergist at the Royal Manchester Children's Hospital. She has an extensive knowledge about peanut allergy, and she's going to talk today a little bit about the advances in this. So over to Dr. Sharma.
Thank you very much for this very kind introduction. I hope you can see me and hear me. Thank you also to AllergyUK for giving me this opportunity. I've been tasked to talk about advances in management and prevention of peanut allergy. What I've done is I've broken the talk into 3 chunks. We will talk first about situations which predispose individuals to developing allergies. And this is in the first instance related to impairment of the skin barrier and talking about other cofactors that lead to facilitation of development of peanut allergy. And then I will talk about early interventions to prevent peanut allergy in infants that are susceptible or maybe not susceptible for development of peanut allergy. So talking about large-scale messages that we could be giving to the population. And then finally, emerging treatments in those who have actually developed peanut allergy and any interventions that we may be thinking of that could be coming in the near future. Before going into those interventions, it'd be lovely to be able to talk about early risk factors that occur in infancy, which may have an impact on development of allergy. And on an epidemiological basis, I would like to draw your attention to the EuroPreval study, which is a birth cohort called IFAM, where we were looking at what could be protective and risk factors. And what was obvious on looking at this birth cohort was that the female gender, having older siblings, and provision of daycare exposure in early infancy appeared to be protective, whereas having family history of allergy, being born by a cesarean section, and development of atopy at early age seem to be risk factors. So these are complex group of things that have an influence. A recent publication has tried to pull lots of risk factors which are shown in the figure as red and protective factors shown as blue. But at the heart of this all lies the problem with a skin barrier defect. If the integrity of the skin barrier is affected, then it seems to lead us to develop more atopic tendencies, sensitization, and allergies. Because of the limitation in time, I will not be able to go through all the protective factors and risk factors, but what I've done is picked on a few things that we as clinicians can make a difference on, and I hope that is useful to you. So just going back to the impaired skin barrier, we know that this leads to development of peanut allergy in an increased proportion. And what happens is that the epithelial barrier impairment predates development of atopy. With the impairment of the epithelial barrier, there is a loss of protective antimicrobial, antiprotease effect, and also there is disruption of transport of ions, protons, and water. And the effect of this is that the transepidermal water loss increases. And with that, there is exacerbation of dryness and eczema presentation. Epidermal differentiation complex is a conglomeration of cells in the top layer of the skin. And it is affected by filaggrin, which has been read extensively and researched, but also by other proteins which are filaggrin-like 2, hornerin, and certain defects of claudins that influence the tight junctions. So, a skew towards impairment of the skin barrier leads to disruption of this neat structure of dermis and epidermis. And this disruption then affects the innate immune responses and leads to a Th2 type skew, which is one that predisposes to development of allergic diathesis. One would think that repairing the barrier dysfunction by moisturizing the skin should be helpful. And early suggestion from a Japanese study did give a signal that if you moisturize the skin regularly and intensively, then you might find that there is an improvement in the sensitization. However, more recently published analysis from the EAT study. EAT study was one of the largest studies inquiring about tolerance, as the acronym, evaluating sensitization and any influence that introducing foods early to breastfed infants starting from 3 months of age, as opposed to them introducing foods at 6 months of age, was looking at. And what they found was that the food allergy incidence was increased in individuals in a dose-dependent manner if they were more moisturized. So here we see that daily moisturizing appears to favor food allergy development. And this held true when infants with or without eczema were put into the equation. The researchers had also extensively read and evaluated these infants on their eczema severity scores, their transepidermal water loss, and had also evaluated them for filaggrin gene mutation. So it doesn't seem to be as intuitive in management, and it is likely that there are a complex interaction situation where there are a whole load of other factors that come into play. We know that there are a great number of individuals, 1 in 10 in fact in Western Europe and North America, who will carry the filaggrin gene defect. We know that carrying the filaggrin gene defect predisposes to development of atopic eczema. It also increases the risk of sensitization and of allergic rhinitis. However, if we look at the risk of development of asthma, it is only increased in those who have actually got eczema and not just the filaggrin gene. So in a subset of individuals carrying the filaggrin gene, there is facilitation of food allergy. And there is bound to be other factors at play which may be protective in these individuals. Let's explore these. Ziab and colleagues have published their evaluation of gene-on-gene interaction. They took 2 large population-based birth cohort studies. One was the Isle of Wight cohort, and the other one was the Manchester Allergy and Asthma Study. And they compared with filaggrin gene mutation, and which is a barrier gene, and the IL4R, which is an immune response gene. And what they found was that if one had filaggrin gene mutation and they were homozygous for IL4R gene, then there was a favor towards sensitization. But this was masked in heterozygous individuals, so these were protected. In practical terms, Gideon Lack, more than 10 years ago now, had coined the dual skin exposure hypothesis. And what it meant was that in infants who had eczema, introduction of food early into the diet seemed to be protective in sensitization and development of allergy. More recently, it has been suggested that the sensitization not only occurs through the skin, but also through the epithelial lining in the lung, where peanut exposure in presence of an adjuvant, such as house dust mite, may be leading to sensitization. So their suggestion is that the sensitization occurs not only through the skin, but also may occur through the airway development. There's an interesting study that I came across, and it is worth a mention, and it is only because it is not to do with filaggrin, but a slightly different axis. Time matters is what these scientists suggest. And it appears that there's a circadian rhythm in the intestinal homeostasis. And what they're suggesting is that mucoadherent microbes in the small intestine affect the MHC, which is the major histocompatibility type 2 complex. And this has an effect on CD4 cells that lead to release of immunoglobulin G4 and IL-10, which enhances oral tolerance when food is introduced through the intestinal active phase, which is the resorptive phase. But if the food is introduced at resting phase, then it may favor disruption of oral tolerance. And I understand that this will be a concept which will be further probed as time goes on. So thinking about the strategies that can be adopted for infants who may have not yet developed allergy or sensitization, or looking at those who have already got symptoms, the stratification seems to be a primary prevention strategy, which would be in infants who are normal, not affected by any atopic tendencies, and will benefit from eating all kinds of foods. Secondary prevention would be applicable to those where there is a risk of sensitization, such as those with eczema. And tertiary prevention or intervention would be in infants where there is already sensitization and also an allergic reaction. So these have shown that they are allergic infants. The strategies in the three groups, as you can imagine, will be different because the risk stratification is different. It's worth also talking about a couple of terms that get used in this context. So tolerant is an infant who is able to eat peanut without any difficulty and does not have any need for ongoing treatment for this. Sustained unresponsiveness. This is a term used in infants where peanut has been given to them, and after a period of exposure, there is a substantial gap where there is no nut ingestion, and then their threshold of tolerance is tested and found that they do not react. So they are unresponsive in a sustained manner. The duration of sustained responsiveness at present, in our understanding, is varying as researches emerge. And the third category, which is transient desensitization, where there is an increase in threshold, and this is a temporary phenomenon, by consuming peanut on a regular basis. And so this is consumption dependent. So stopping ingestion of peanut reverts back to the reactivity to peanut and therefore the risk of an allergic reaction. Thinking about influences that we as clinicians can make, this is a good study to think about. So it is the Isle of Wight cohort study, and they were studying the impact of early breastfeeding on development of eczema at 1 and 2 years of age. To simplify this slide, on the horizontal axis, we're talking about duration of breastfeeding in early life, starting as a timed assessment. The vertical gray bars show the cumulative proportion of infants receiving breastfeeding. And so at 1 week of age, there are about more than 75% who are receiving breastfeeds, and so on and so forth. The dark circles here and this line represents the risk of development of eczema in individuals who have filaggrin loss of function. And the open circles represents those who do not have the filaggrin mutation. And so what we see here is a reduction in risk in infants carrying the filaggrin gene mutation with persistent breastfeeding. And this is not seen in those who do not carry the filaggrin gene mutation. So a breastfeed in a susceptible infant is going to have a longer term impact. And one wonders why this could be the case. So it appears that allergen shedding in the human milk can be educating the immune system in maybe development or prevention of allergies. Breast milk is not just passive immunity against pathogens. There is an active interaction which may have a long-term beneficial effect of no allergy or maybe increased allergy. There have been studies which have shown that house dust mite allergen transfer leads to immune activation and sensitization of allergens. This is the most studied inhalant allergen. The other aspect of it is a regulatory immune response, which is immune activation and tolerance induction by ingestion of allergens by the mother. And the authors propose that the exogenous sources of allergen which the mother consumes, including milk, egg, peanut, wheat, are passed through the breast milk in very small amounts, are digested, presented with an antigen presenting cell, and maybe in microvesicles in the milk, bound to immunoglobulin A or immunoglobulin G, and in presence of immunomodulators in the human milk, and receiving the advantages of the maternal microbiome, which of course is a tall order to ask from an infant formula. And cumulative effect of all these may be the beneficial effect of breastfeeding in the immune tolerance phenomenon that is seen. This seems to have been reinforced by a study which was published in JACI in 2018. The researchers there were evaluating the sensitization to peanut at 7 years of age. And what they found was that if a breastfeeding mother was consuming peanut whilst breastfeeding, and the infant consumed peanut before 12 months of age, then this was protective when compared to if the breastfeeding mother was consuming peanut alone, or if the child was introduced to peanut early. So in essence, passive exposure to the food via breastfeeds and direct exposure with early weaning seems to reduce the risk of peanut sensitization in the longer run. There are other studies that have reinforced this, and the biggest of those is the LEAP study, so learning early about peanut. And what was seen was that infants that were not sensitized to peanut by skin or blood testing showed a statistically significant reduction in the consumption group with reduction in peanut allergy development. Likewise, infants that were positive on blood testing to peanut or skin testing positive or a combination of two, when given peanut on a regular basis, showed a statistically significant reduction in development of peanut allergy. And interestingly, this held across different races. The other study that reinforces this is the EAT study, and that is the inquiring about tolerance. And it was a study which involved infants at 3 months of age versus introduction of foods at 6 months of age, which would be the standard of care in the UK at present. And when the researchers had done their per protocol analysis, it was clear that there was a significant reduction of peanut allergy and, in fact, egg allergy in those infants where there was early introduction of peanut at 3 months as opposed to 6 months of age. So this was about infants who have not developed allergy. Now, when infants have developed allergy and have got a convincing reaction, which is an immediate reaction, then the tables change a little bit. So we know that if you've had twice you have seen a reaction of a clear exposure to peanut, then you're more likely to be testing positive to the allergy tests. And just as a background, and I know you may all be aware, but just to get us all on the same page, nut allergy, the peanut allergy, may be either a primary nut allergy, where you can be more predisposed to severe systemic allergic reactions, and the sensitization is generally to the major storage proteins, as opposed to the pollen food syndrome or the oral allergy syndrome, which is generally seen in individuals related to allergic rhinitis. They react to fresh fruits and vegetables. The reactions are mild, generally isolated to the oropharynx. Anaphylaxis is uncommon, and the sensitization is to heat labile proteins, which are homologous to the pollen, that is profilin 10 homologous proteins. BSACI, British Society of Allergy and Clinical Immunology, has laid down extensive guidelines on evaluation of peanut allergy, and I will not go into details as these are readily available on the website. But it is important to understand that the follow-up of individuals at present with peanut allergy involves ongoing education about how to recognize and manage allergic reactions and ongoing active avoidance of peanut. As opposed to that, immunotherapy to peanuts offers a chance of making an active intervention. I'll talk about 4 studies that I've chosen, though there are multiple which you may be able to access. The first 2 studies, Palisade and Artemis, were evaluation of safety and efficacy of an oral product that has now been licensed in the US. And it showed a significant advantage in receiving this product in peanut allergic individuals as compared to those who received placebo. The third study that I have listed here is the early oral immunotherapy study, which involved infants between 9 and 36 months old. So these were infants who had had an immediate reaction to peanut and were almost soon afterwards recruited to the early oral immunotherapy. They evaluated the maintenance dose of 300 versus 3,000 milligrams. And interestingly, they found that 78% of these infants had received peanut at either the 300 or the 3,000 milligram, showed 4 weeks of sustained unresponsiveness. So what this study shows is that an early intervention made soon after peanut allergy is diagnosed in infancy can disrupt development of peanut allergy. The bigger example of that is the Leap On study, where infants had received peanut for the first 5 years of life, and then for 12 months they had avoided peanuts. And the outcome of this avoidance was that those who had consumed peanut for the first 5 years were developing allergy in the order of around 5%, as opposed to those who had been avoiding in a much larger and a statistically significant proportion. So this effect of early introduction of peanut leading to tolerance was not just a transient, but a longer lasting impact. There are other strategies apart from oral immunotherapy that are now being very actively pursued. These involve use of biologics, treating eczema aggressively, epicutaneous immunotherapy, and use of probiotics, amongst many other efforts that have been ongoing. So to conclude the talk, sensitization is dependent on skin barrier dysfunction. And this nature of sensitization and then going on to develop food allergy is complex. But what we know in simplistic terms is that breastfeeding offers advantage. And if the mother's consuming peanut whilst breastfeeding, then that has an advantage and appears to be protective. Early introduction of peanut to the diet is also advantageous. And so it is a good message to give out to our populations. Once you're found to be tolerant to peanut, then regularly exposing it in the diet is of advantage. And it'll be helpful to understand the distinction between those who are merely sensitized to those who are allergic, because the strategy for dealing with the two groups is going to be different. Peanut oral immunotherapy is now available in the US and is on the horizon in the UK. And this will require careful patient selection and concerted efforts on follow-up arrangements and encouragement for sustained compliance of these treatments. Thank you, and I'll take questions if you've got any.
Thank you very much, Dr. Sharma, for such an informative talk. It really shows kind of where we're at peanut allergy in the UK at the moment. I'll invite anyone to offer some questions over to Viba. Please submit them via the Slido. I just wanted to start off with a question. You talk a lot about it's good, you know, for breastfeeding and introduction of peanut early for prevention. How much anxiety do you have, you know, when talking to parents around this? So the early introduction in high-risk patients, do you struggle with that?
I feel very reassured from the big, large LEAP study that has been shown to be protective in individuals who were at high risk. So if you look at the LEAP study, it was actually targeting individuals who were at risk, and they were identifying this with infants having history of eczema, family history of eczema, or egg allergy, which predisposes infants to development of peanut allergy. And so there was a good degree of assurance that the LEAP study provides. So I am quite forthright in encouraging individuals to introduce peanut to their diet. I've got to say that I can't see you or anybody else. And so if I'm looking like I'm looking in the oblivion, it's because my screen's a little dark and slaty.
No, don't worry. You're doing great. Thank you. You talked a little bit in your talk about emollients and the risk of kind of allergies. We've got a question. Do you recommend daily emollients in atopic babies prone to atopic dermatitis to prevent food allergy?
So this is a very interesting question. So it depends on what you're using to moisturize. And in the EAT study analysis, it is rather interesting that daily emollient use in individuals who don't need emollient or needing emollient was related with an increased incidence of food allergy. And if we break this down a little bit, it is useful to think about why this could be happening. So one of the suggestions is that the parents are moisturizing their children and have not washed their hands properly to get all the food allergen off their hands. The second is that when you're massaging an infant with an oil, then you may somehow be introducing the allergen into the skin, into the deeper layers of the skin. And the third is that the emollients themselves, they vary in what they are constituently made of. And so we know that sodium lauryl sulfate, which is a constituent of soaps, but also was available previously in some of the moisturizing solutions, could be disruptive to the skin. We also know now that the olive oil or some of the nut oils, which are very frequently recommended on postnatal wards and by families, have a negative effect on the lamellar layer of the epidermis. So we may be doing some harm with this. And it just leaves you with the anxiety that we may be doing some harm with it. Now, there are early suggestions that there are some creams which have got ceramides and a combination of certain lipids, trilipids in particular, which may be showing an advantage and may have a protective effect on the skin. So it's not a straightforward situation to be advising on, really, if that helps.
No, definitely is complex. Exactly. I totally agree with you. So there's a little bit of questions about a couple of questions about immunotherapy.
Sure.
How far are we achieving this in the UK at the moment?
Okay. So if we talk about prevention strategies, the primary and the secondary prevention strategies, I think the number of individuals who are taking up peanut early in their infant's life and they are eating peanut through pregnancy and through breastfeeding, that number seems to be increasing because I see that in my clinics now. Children coming with cow's milk allergy and egg allergy have already introduced peanut to their diet, which is delightful. The specific word you've used in the question is oral immunotherapy, and that is a different issue. So the oral immunotherapy would be provided or should be provided to individuals who are allergic to peanuts. And this is involved with a certain degree of risk. So the oral immunotherapy at present is not available on the NHS as a treatment strategy in a standard fashion. There are research studies which are delivering this, and there are some very small centers, also large centers with small cohorts of individuals who have been given oral immunotherapy using native peanut protein. So in a straightforward answer, at present, oral immunotherapy in the UK is not a prevalent standard treatment modality in peanut allergic infants.
Okay. And when it is, and like you mentioned the US, is the goal of the immunotherapy for peanut allergy complete tolerance or to prevent anaphylaxis? What's the final goal of it?
That's a fantastic question to ask, and I'm glad you've asked it because I didn't cover it. So the point at present of providing oral immunotherapy is to give a little bit more security to the individuals who are receiving the immunotherapy. And what you've got to understand is that these are allergic individuals, and we have only raised the threshold at which they react. So a very small amount of peanut exposure could have caused a severe reaction, whereas after receiving peanut in a regular manner, what has happened is that these individuals will have a reaction at a higher dose. And the dose at which they will react can be quite high in some individuals. But also we know that we have risk factors which predispose us to have allergic reactions. So for instance, an individual may have a virus infection, they may be unwell on a day, and on that day, their tolerance threshold will drop. And so this threshold being not very static makes it difficult for us to say, well, we've done the challenge and we've seen you that you can eat 8 peanuts or 10 peanuts in the ward, because we do those challenges on a day when you're well, that you can go on and eat peanuts freely because the threshold will vary. And so the bottom line here is that it provides safety for exposure to a chance encounter to peanut when they are out and about, but it is not for them to freely consume peanuts when they're eating outside of the house or even within the house. So the measure is a introduction of safety rather than complete ad lib
Resolution.
eating of
Yeah.
peanut.
No, absolutely. I agree. We've just got a couple more questions. So you say egg allergy appears to predispose peanut allergy. If they outgrow their egg allergy, does it have a relation to how quickly they outgrow their peanut allergy?
Right. So there's a very interesting one. So there is an association of peanut allergy and egg allergy. So those infants who are egg allergic tend to have a greater incidence of developing peanut allergy. And this association is not very clear. It doesn't mean that if your egg allergy resolves, that your peanut allergy will also resolve. By and large, peanut allergy is a lifelong allergy. And if you've got it, then you're allergic for the rest of your life.
Yeah, no, absolutely. Okay, moving on to one more question, and you touched on it in your presentation a little bit about ethnicity. So have you seen any difference in the onset of peanut allergy in eczema patients in different ethnicities?
So this has been very well documented in several studies. There was a big study from Melbourne that in Australia, their cohort had shown quite clearly that in immigrants who were coming into Australia and were of Asian background, the incidence of allergy or to the peanut allergy was higher than those of the people who were native Australians. Okay,
perfect. So slightly higher. So thank you very much for your talk today. It's been very interesting, and the research clearly seems to be moving forward quite quickly in lots of areas of peanut allergy. So we really appreciate your time spending with us today, and thank you very much, Dr. Sharma.
Thank you so much for the opportunity.
Okay, no problem. So we're running 5 minutes early, but we're going to move on to our next talk. It's our pleasure to have Dr. Chrissy Jones here today. She's a reader in clinical health psychology at the University of Surrey. And so I'm going to hand over to Dr. Chrissy Jones.
Lovely. Thank you so much, Laura, and thank you for inviting me to speak about this really important topic and something that's really close to my heart. I've been working in the field of food allergy for about 15 years now, and I'm really, I guess, motivated to try and improve outcomes for patients, individuals, and families generally. So I'm going to be talking about the psychological impact of food allergy. And just to say, my kind of day-to-day role is actually training clinical psychologists to become clinical psychologists. So I supervise a lot of research, and kind of my focus of the research is actually developing psychological interventions to try and help people with food allergy and help them manage the anxiety and the worries that come with having a diagnosis of food allergy. So I just want to talk a little bit about psychological impact throughout the allergy life course. So if we think of an allergic condition, and in fact any long-term condition, there is of course emotional, psychological and financial implications. And we know that specifically with food allergy, there are kind of pinch points, if you like, throughout the course of a diagnosis, where people are likely to experience more worry and more anxiety and more stress, and lead to kind of an impairment in quality of life. And we'll just look at some of the evidence around these. Pre-diagnosis, food allergy challenges come with their own challenges psychologically, and then during the diagnosis, coming to terms with things. Then there's also issues around medication and management. And then specifically for parents and children, there's something around transition periods and how we move between independence and how we negotiate that between parents and children. And then there's the obviously maintaining self-care. So how do we keep ourselves well whilst having a diagnosis of food allergy? So I just want to talk first about the psychological impact on parents. Now, I should say these are not to scare people in terms of the amount of evidence, but what I'm hoping to do for all of those of you who work with food allergy populations is really just to show you how broad the evidence base is here for how people and why people feel anxious. And that's really so that you can try and empathise with your patients and really try and normalise some of the concerns, because that can be massively helpful for patients if they just feel like they're not alone and you can understand some of the difficulties they're facing. So what we see in and of itself is having a diagnosis can cause significant stress. As you're probably aware more than most, the process can be incredibly lengthy and challenging, and frequently involves multiple tests, return hospital visits, and access to specialist services, which can all have long waiting times. So unsurprisingly, parents may actually experience anxiety and depression during and prior to a child actually having a diagnosis. And what we find is that actually for some, that anxiety level drops after a food challenge because they have the certainty of knowing what the allergy is, but then obviously the uncertainty of how to manage that can kick in. We also see that actually anxiety related to allergy is higher if there are multiple allergies, or if the child is allergic to ubiquitous foods such as wheat, so where foods which we see in lots of different products. And there's also a high level of responsibility, stress and burden related to parents in terms of their own self-efficacy or competence in knowing how to manage their child's allergic needs. Obviously, that kind of burden and responsibility can cause massive difficulties for the parent to kind of hand over care to others. And what that ends up doing is kind of a self-fulfilling prophecy. People reluctant to hand over care, and actually creates more impairment on quality of life and more responsibility and more guilt. So it can be really problematic for some of the parents we see. We know that especially with peanut allergy, knowledge is required from a whole family and wider social network, and siblings often are worried about their food allergic siblings' well-being, their peanut allergy. We also know that carers are instructed to maintain a very high level of vigilance, which sometimes means they pose excessive risks on themselves, their family and their children, which can lead to restriction of some social occasions, which can have knock-on implications for the social development of the child. We've also seen from some of the evidence that children prescribed an adrenaline auto-injector report higher levels of anxiety, and we're not sure what that's about, but it could be an indicator of severity. So parents see their child as having a more severe allergy. So if we think about the impact, moving from the parents, if you think about the impact on individuals at the time of food challenging, obviously there are people who have to face their fears even within a secure environment. You know, you've been told to avoid particular things, and then you're going to be challenge. So that can really cause some difficulties for the individuals themselves. We also see post-food challenge experiences where some children will continue to avoid foods even if they have have passed a challenge. And, you know, there's some question about whether that's it's led to some disordered eating or avoidance of that. We don't really understand what's going on so well there. We also see, again, as we see with parents, children who've got multiple allergies have got higher impairment in quality of life, and often children report feeling isolated, bullied, and kind of excluded during schools. And there are kind of very explicit examples of that in some qualitative research, where children have said that they put peanut oil on the slide so the child can't use it, versus to other children reporting that they feel really unsafe or excluded because although they're the ones with they're the ones with the allergy, they're almost being pushed out and outcast onto separate tables or excluded from trips and things because of their allergic disease. And as the child grows, we see the bullying can continue, but then also as the child ages and becomes a young adult, there's some concerns around dating anxiety and fear of negative evaluation by the opposite sex. So this isn't something that just happens at one part of childhood. It can continue throughout. So why do we think food allergy might impact on psychological well-being? Well, there's kind of several aspects which really end up feeding back onto themselves. So we know that avoidance of the allergic trigger is absolutely key to managing the disease effectively, and reactions can be life-threatening. However, we also know that with the best will in the world, accidents happen and avoidance is not always possible, and it's not always down to the individual's own behaviour. There's also no cure currently for food allergy, and this can lead some people, as I mentioned earlier, to be extremely hypervigilant. And obviously, this is just works on a feedback loop. So there are some hypotheses between food allergy and anxiety. So there's a biological hypothesis that actually allergic reactions trigger a stress response and change our brain's neuronal activity, which actually leads to adaptive behaviours similar to those in anxious, we see in anxious avoidance behaviours. And I'll talk a little bit about that in more detail later. We also can understand from a cognitive behavioural perspective that anxiety, which is associated with persistent negative cognitive biases, and these biases, such as worry around high perceived risk, coming into contact with the allergen and potential anaphylactic reactions, lead us to behavioural avoidance. Now, obviously, a certain amount of avoidance is imperative, as we know, but some avoidance feels overly restrictive, and again that can lead to impairments in our quality of life when we think we're missing out on opportunities, or we're worried that our children are missing out on opportunities. And then we've got environmental hypotheses. So we know that anxiety is a learnt behaviour. So parents may actually share their worries or model anxiety and anxious restrictive behaviours, which their children then pick up on. And we know in the literature that if you are an anxious parent, your child is 7 times more likely to meet an anxiety disorder of their own. So the learnt behaviour and environmental interactions are quite strong here. So I just wanted to move on to kind of the types of psychological interventions and the evidence behind those that we have at the moment for food allergy. So to say, firstly, really that the majority of psychological interventions have focused on cognitive behavioural therapy, and they have focused on parents. Now, that's likely to be reflective of the fact that most food allergy is diagnosed in younger children, and the responsibility and management rests pretty much entirely on the parents at that point. And as I mentioned, one if a parent is anxious, the child is more likely to develop their own anxiety disorders. And there's been quite a few calls and for recommendations that we try and address excessive anxiety in parents. And cognitive behavioural therapy is one of the most recommended techniques for reducing anxiety. So I think that's probably why we see so many psychological interventions focusing on this aspect. So I just wanted to kind of, you may be aware of the term formulation, especially if you've done any kind of psychological work with patients yourself. But I wanted to kind of give you an example of how a formulation might work. And this is specifically for parents of children with food allergy, although you could easily apply it, and we can look at some examples of how you might apply that for individuals or children. So if we think about the kind of, you're in a situation and the sorts of thoughts that might provoke, a situation might provoke in you. So for instance, a child going to a birthday party. So my child will have a reaction. I won't be there. If I make a mistake, I could cause my child harm. I'm a bad parent. My child will feel left out at school. So these, from speaking to parents, these are really, really common concerns that come up time and time again for parents. And what these thoughts invoke in us is some physical and emotional reactions. You might feel physically tense, tired, headache, sweaty. You might feel anxious, stressed, with low mood, feeling guilty and responsible. And you may also employ some behaviours. So you might avoid new people and new situations. You might ruminate, and you might constantly check your phone if your child's at school or away from you. And that constant checking, which in this case could be unhelpful, that's what we call a maladaptive safety behaviour. So actually what it does is it serves to maintain our anxiety instead of allowing us to realise that our anxiety would dip on in and of itself. I think the other thing to say is it can cause arguments between families where people think one parent might think one of the other parents is being too excessive, and that can cause conflict, which is not helpful for anyone in this situation. And really the whole idea about CBT is never not to experience anxiety again, but it's to have a bit more of a balanced perspective and not to allow the anxiety to impact your quality of life. So how might we go about breaking this kind of vicious cycle of anxiety? Well, one of the key things is to identify the trigger situations. So if we can understand and see a pattern to what or when or with whom we're most likely to feel anxious, we might be able to respond differently. We might also want to confront avoidance or safety behaviours. And when I'm talking about avoidance here, I'm not talking about of the allergic trigger. I'm talking about avoidance of things such as social situations, which might be unnecessary to avoid. We might also trial some balanced thinking. So this is where we put our thoughts, because often when we're anxious, we think our thoughts are facts, when in fact they are thoughts. So we put them on what we call trial. So we look for evidence for and evidence against those particular negative thoughts that we're having. We also need to really manage the physical sensations of anxiety. So what we know is that actually being tense and can actually make us feel more anxiety. So shallow breathing and tense muscles are linked very much to worry and anxiety. So if we can try some mindful breathing, muscle relaxation, or exercise, that might also be helpful. And lastly, understanding what is and what isn't a problem. And this really relates to a technique called the worry tree. And there are some really nice resources. I've linked to AllergyUK website here with Coping with Anxiety, which goes into some of this in more detail. One thing I just wanted to mention here is the symptom overlap between anxiety and allergy. And this is also one of the reasons why we might mention relaxation techniques, because as you can see, there are some significant overlap between anxiety and having a severe allergic reaction. And what we don't want people to we're not advocating that when you're having an allergic reaction, you try mindful breathing. That's not going to work. But it's just about being familiar with the symptoms that you might experience. And of course, if you are worried at all that you're having an allergic reaction, follow the emergency anaphylaxis management plan that you've been given by your hospital staff. So I guess what I also want to kind of advocate and really stress that actually not all anxiety is bad. So here we kind of see a continuum here, and what we're looking for is the sweet spot. And now the sweet spot is not the same for every individual, which can make working with people with food allergies or their parents quite tricky. So we see on the kind of left-hand side, not enough worry, no assessment of risk, no carriage of adrenaline auto-injectors, and a high risk of accidental exposure. Now that's problematic. They're unlikely to feel anxious, but they are likely to experience an allergic reaction. Now, I think most parents see their children in this kind of area, which often leads parents to feeling quite anxious themselves. And then if we look at the other end of the spectrum, we've got those who are highly stressed, anxious, worried, and distressed. We see hypervigilance regarding risk. So we're expecting to see risk even when there isn't any, which can lead those physical sensations of anxiety, making us potentially think that we're having an allergic reaction, as per previous slide. And it can lead to impaired quality of life. But what we're looking for is a good self-efficacy. So here's where we understand the risks. We know how to use our emergency medication. We know what to do in the case of an allergic reaction. We've got a good understanding of the risks and how to take care of ourselves or our children. And we really have a balanced quality of life. So we don't feel like we're missing out on things because of the allergic diagnosis. Really, you're kind of wanting, if you're thinking about where you want to intervene, it's either end of that kind of green yellowy spot. But as I say, can be different for different people, because whilst we may think someone is being excessively hypervigilant or avoiding things, they may not see it as a problem for themselves or their family, and that can be difficult to negotiate. So I wanted to give an overview of some recent psychological evidence which I've been involved with. And I guess this is to be a bit hopeful about what we've been working on and the developments we have in psychological interventions for food allergy. So this first study I wanted to mention is all about raising confident kids with food allergy. So it's a parent intervention. It was run over a week with 2 sessions either side of the week, and it was a 2-hour online workshop, and it was delivered by one of my trainee clinical psychologists, Stephanie Vrieken-Ross. You can see the publication is at the bottom here. And basically the whole idea of this intervention is to help parents reduce the transmission of anxiety from themselves to their children within the context of food allergy. So it's all about how do you parent to raise a confident child with food allergy. And what we saw at 3 months post-intervention, the parents' anxiety and self-efficacy had, anxiety had reduced and self-efficacy had improved. And we also saw a reduction in parent-reported child anxiety for children aged 6 to 16 years, but not the under 6 years old. And that might be because we didn't, when we split the groups, there weren't so many in the under 6 years old perspective. One of the reasons this is particularly exciting is because it's a manualized intervention. So it follows a workbook. There are slides which are created. And what that means is it might be possible for us to train non-psychologists to deliver this within practice settings. So especially with allied health professionals, dietitians and nurses who may feel like this is an intervention that they might want to start using within their practice. But we need to see if we can actually do that. So we're looking to get some more funding to evaluate whether allied health professionals can in fact deliver this with good intervention fidelity. I'm also involved in 4 other randomized control trials. So some of these are CBT-based workshops. So one thing we're desperately lacking is adult psychological interventions. So we've adapted a CBT group workshop. Again, it's manualized. We also have another parent trial, which is again a manualized intervention. And this is to help parents manage their own anxiety rather than the transition of anxiety. And we've also created a workshop for children as well. So those trials are currently running. We've finished the interventions. We're just collecting the outcome data at the moment. So we hope to have that data in the next, I'd say, the next 3 to 6 months. And then finally, for something that's a bit more intensive, we're also running a trial of mindfulness-based cognitive therapy. And this involves 9 to 2-hour group workshops. And with all mindfulness-based interventions, you are expected, or parents are expected to do quite a lot of home practice, so practicing mindfulness in between sessions. So that's kind of what we're doing from the psychological intervention and research perspective. But what else are we doing to try and improve psychological health for our patients and families with food allergy? Well, really exciting. We've just announced that the British Society for Allergy and Clinical Immunology has a psychology working group. So that has just been set up, hot off the press from this weekend, and that's being chaired by Rebecca Knibb, and I'm one of the members of that group, as there are several other members. So fantastic news. And we also have a specialist interest group relating to the British Psychological Society. And here is all about advocating and raising awareness of psychological needs. It's about developing and increasing service provision. So really, we know that specialist services for allergy across the UK are not equitable. So it's about, can we build business cases to incorporate them in services across the UK? It's also about sharing psychological resources and evidence-based. So the types of interventions I've described, how can we roll those out across the NHS? And it's about developing existing research and initiating and proposing new research. So I'm really excited that we've got these 2 initiatives. What else do we need to do? Well, we need to explore different types of psychological interventions. Whilst CBT is very popular and has a large evidence base for lots of health anxiety, it does not suit everyone. So we are looking at other interventions, such as I mentioned, mindfulness, and perhaps there will be some other interventions such as peer support or self-compassion, which might be more appropriate. So more work to do there. We also need to work out which interventions work best and for whom. And we also need to work out, conduct research in generalizable populations. So we know that men and fathers specifically don't tend to come to psychological interventions, and the minority, ethnic minority groups are not well represented in the psychological research to date. So we need to make better moves forward here. I just wanted to kind of finish up with the things that you might be able to do. And I mentioned about normalizing. So if a patient or family are talking to you about their concerns, try to be empathic and normalize their experiences without minimizing them. So you can say things like, this is not unusual, there is quite a lot of evidence, and then direct them to AllergyUK websites. You can signpost and refer to the improving access to psychological services as well. You can recommend them to patient support groups. And I've linked to some of the evidence base here. So we know that being a member of support groups is actually related to an increase in positive self-care behaviours. So, you know, there's something there that it's not just reassuring, there's some outcome data as well in terms of physical outcomes. And we know that goal setting and planning can also be beneficial to improve self-management. Really simply, please ensure that your patients have an anaphylaxis management plan. There's some nice studies which have shown associations between reductions in severe reactions when you have an anaphylaxis management plan. And there's some, again, data regarding adherence to positive self-care behaviours. And finally, really think about how you can address your own knowledge gaps. So we conducted a systematic review a couple of years ago of how health professionals, patients and parents use the adrenaline auto-injector. And it wasn't great, to be honest with you. And it's perhaps unsurprising that patients have got a low percentage of uptake of correct administration, when actually healthcare professionals do too. So think about whether you can have a training advocate in your clinic or your service, and don't assume that someone else is going to be doing that training of their patients, because it's not always the case. So I guess just to summarize, peanut and other food allergies impact the whole family, not just the individual, and the impact and related needs actually are likely to change across the life course, but probably not be removed completely. We can see that there are several hypotheses for the link between allergy and anxiety, and these may include biological, environmental, cognitive and behavioural. We are also kind of encouraged by the psychological research which is happening, although we need to do more research in interventions outside of CBT. We need to ensure that other groups other than mothers and women and those from more diverse ethnic groups are also represented in the research that we are doing, so we can see if they're generalizable across populations. But there are also a number of protective factors and several simple changes that you could make to your clinical practice, which can positively impact individuals and their families. I'd just like to thank you for your time, and my email address is there. If you've ever got any research ideas that you'd like to take forward, please do get in touch, because we always have lots of very willing trainee clinical psychologists to work on things over their time with us at Surrey. And yes, thank you again.
Thank you so much, Chrissy. It's such an interesting talk, and I think we can all really relate to this in our practice, that it is a big deal. We have got a few questions, and I'd invite anyone to add any more in the next few minutes. We did have one submitted prior to your presentation, so they couldn't attend it today, but did want this question answered. I feel you covered it to some degree in your talk, but children who are at risk of anaphylaxis really struggle with warnings like may contain, and also trust issues when eating out. They become over-selective. They have brand loyalty, and they need a lot of reassurance. How can we get this balance for these individuals?
I think it's a really important question. I guess to some extent, is having brand loyalty and staying to one restaurant or one chain of restaurant, is that a problem? And if it's not a problem, continue doing it. But I think it's when that kind of vigilance becomes so restrictive that they're not eating anything or they're not going out at all, I think that's the problem. And that's on that kind of spectrum I showed you. This is why it's so key to really explore some of these factors, because for some individuals who they may not go out to eat, they may not see eating out as a big deal or part of their family, makeup or whatever. So for some, we may think it's an issue, but they may not think it's an issue. So that's why it's so important to find out what is and what isn't a problem for some, because it just might not be, high on their priority list.
No, absolutely. And if it's not high priority to then go and do that, it's putting them outside their comfort zone and making the situation worse. So
I think,
no, absolutely. It's really encouraging about the BSACI psychology group, really good. We know in other areas of health, so for example, type 1 diabetes, psychology is really seen as routine practice now in NHS MDT clinics. Is there any hope in the future that could happen in allergy? I am aware it happens in some clinics, which is amazing, but not universal at the moment.
I think that's the dream, to be quite honest, Laura. I think that's what we're striving for. And really, I think, as you say, diabetes have done very well, but they've got a better research base as well than food allergy. So I think we're slightly behind them, if I'm being honest. And that's why I'm so keen to kind of show that these quite low intensity psychological interventions can have impact, not just in psychological outcomes, but potentially on the physical outcomes as well. So if we think more of our well-being as not one or the other, but a very holistic approach to quality of life and well-being, then I think it makes the business case to hospitals as to why you might have a psychologist in your team. But also my goal is, because even in our curriculum for clinical psychology training, we look at long-term conditions generally, but we don't specify food allergy, for example. And there are some unique aspects, as we've discussed, why food allergy might make you more anxious than, say, other more symptomatic or regularly symptomatic conditions, say like asthma, for instance. Now, if I'm doing research of all these trainees, what I'm hopeful of, even if they move into generic health psychology and teams, they've actually got an awareness of those the psychological aspects of food allergy. So hopefully they'll be well placed to kind of support them moving forward. But really, that's what we're trying to achieve. And I think the more evidence and the more research we can generate, the easier it will be for psychologists to make the business case for their employment, I guess, within the NHS trusts.
No, absolutely. We all hope this too. So we have a question. Is there any evidence of an increased incidence of eating disorders amongst allergic individuals or their parents?
That's a really, really good question. As far as I'm aware, no. But this, I also do some research in eating disorders in type 1 diabetes. And when you speak to parents, actually, the parent could easily be someone with a child with food allergy rather than type 1 diabetes. The same patterns in qualitative discussion are coming up. So I suspect that this could be an issue, but pending further evaluation. And this is something that I'm looking to work on later on in this year. So we've got another cohort of clinical psychology trainees that I'll be supervising, and I suspect this will be a popular area for people to look into.
Yeah, no, definitely. Okay, last question. Are you aware of any adapted parenting programs for parents of the younger ones with allergies or other long-term health conditions?
Yeah, so the Raising Confident Children research that I presented, so the link is on there actually for the article, or email me if you want a copy of the paper. I'm not sure if I'm allowed to say that, but do it anyway. We actually, the parents of the children were aged 2 to 17 years, actually. So we did actually do the intervention and adapt it for children as young as 2. It's just we didn't see a reduction in the parent-reported anxiety of those under 6. Now, that might be, I'm not sure why, we need to explore probably, but yes, so we are working with groups as young as 2, with the parents of children as young as 2.
Perfect. Yeah, that's great. Lovely. So we've got through all our questions today. Is there anything you wanted to add before we complete today?
No, I don't think so. Just again, thank you for having me, and I hope the session's been useful to everyone listening.
No, really useful. Thank you so much.
No problem. Thanks, Laura.
Okay, so we're running slightly early, but I'm sure you're all very busy today. So we're going to move on to our last topic of the day, and that is hope on the horizon for food allergy. It's a pleasure to introduce Amina Warner. She is Head of Clinical Services at AllergyUK, and we are always trying to drive things forward here at AllergyUK. So I'll hand over to Amina.
Thank you, Laura. Thank you for that introduction, and so far such great speakers. So I wanted to sort of put it all together and see what type of hope there is for people with food allergy, because you've heard about how it affects people. So what is what hope is there? What research has been done, and you know, what is the way forward here? So you've heard about the allergic reactions to food, and very common culprits are hen's eggs, cow's milk and peanuts, especially in the paediatric population. It can have a devastating effect on individuals' health, resulting in anaphylaxis and worst case scenario in death. We hope that no child should ever die, no person should ever die from allergy, but it does happen. And the quality of life for not just the person with allergy, but also the family and those that care for them, that it can have an impact. And also behind that, we have to consider as healthcare professionals the substantial healthcare costs as well. So we know within the United Kingdom some prevalence data, it's very high. We are considered a high income country, and up to 1 in 10 people live with food allergy, and the highest prevalence being amongst infants and young children. And still, you know, we would love to know exactly why. We think we know some answers, but we're still learning. Next slide, please. So what do we do to support people? I'm just here picking one aspect of food allergy. So if I look at peanut allergy, we've got a helpline, and our helpline advisors are there to signpost people to aspects on our website, maybe some of our resources when people request them, and maybe escalation calls up to clinical as well. So they do quite a lot, and people often when they travel, they want translation cards, which we provide a service for, so that there's quite a number of different languages that people can get our translation cards, and they're very, very helpful, and especially as some people now are starting to travel again, and so our helpline does receive many calls from parents. And when we consider just peanut allergy alone, there are so many calls that we get from parents reporting that their child has a peanut allergy, and they're looking for some supportive infrastructure there. And AllergyUK website launched a dedicated peanut landing page in 2018, and to date there have been over 73,000 visits to that page. Next slide, please. So we know that peanut allergy is common in the UK. It's characterised by an IgE reaction, so an immediate reaction to peanut protein. So depending on the diagnostic criteria used, we know that between 0.5 and 2.5% of children have allergy to peanuts. And there is some data about whether this prevalence is increasing or not. We do know from some of the literature that infants with severe eczema and or egg allergy has a higher risk of developing peanut allergy. So you would have heard that within the presentations today. So that probably hasn't come as a surprise to you now. Peanut allergy, and we're talking about primary peanut allergy here, because sometimes, and you probably would have heard about the pollen food syndrome. So that's another topic of our masterclasses we've done before. But primary peanut allergy usually presents in the first 5 years of life, and it persists into adulthood. So that is a lifelong condition for these people who have first of all been sensitized and then develop symptoms of peanut allergy. So it is a chronic condition and it's lifelong, and currently there is no cure. So like other food allergies, it's associated with impairments of social, academic, psychosocial and family functioning. And when you heard Chrissy speaking about how it impacts on the family and the individual, that will bring all that to life. Next slide, please. So we wanted to explore and capture some insights of parents with children with peanut allergy to better understand their needs. So this is just one survey. So occasionally Allergy UK, we look at a topic and we want to get more insight into that particular topic. And it may be because we want to lobby for change in that. We might actually want to bring it under the spotlight spotlight of decision makers, etc. So we want to actually better understand what people, their experiences, their lived experiences. And so we went out and did a survey. It was an anonymised questionnaire that we did, 17 questions, and we were very, very surprised. The questionnaire went to over 5,000 parents through our sort of our database and social media, etc. So it's open to all. We're not a membership organisation, so all our resources, everything is free to anybody who finds their way to us or we engage proactively with. So it went out to a significant number of parents with children between the ages of 2 and 11, and we were very surprised by how quick responses came in. And so within 48 hours, we got well over 1,300 responses back. And this, you know, we had in mind that we were going to leave that on for a few weeks, but we'd got a good population, a good cohort that responded. And of those parents that responded, the ones that actually completed all the questions, so we had a complete data set of all the questions to really analyse, we actually considered for this survey and did the analytics on that. So there were over 1,000 of those respondents that completed all those questions. And so we know that their peanut allergy was diagnosed by a healthcare professional, and the majority had received their diagnosis from a paediatric allergy specialist in a hospital. And so despite high levels, so they would have actually been seen by a paediatric allergy specialist and hopefully has an anaphylaxis management plan. They should have been given adrenaline auto-injectors, 2 adrenaline auto-injectors, and also told strict avoidance and how to manage any symptoms that might be suggestive of anaphylaxis. And so they would have had a whole peanut allergy management strategy. And what we found from our questionnaire that we distributed and the parents completed these questions, we found that in spite of high levels of compliance and implementation of these management strategies, the children were still experiencing allergic reactions, and these parents were being very vigilant. They were teaching the children to be vigilant, etc. But still, in spite of best efforts, they were still continuing to experience allergic reactions. So what we found not surprising, that among parents whose children experienced collapse or floppiness or unresponsiveness or breathing difficulties, the prevalence of very worried parents was substantially higher. And so that didn't come as any surprise, because this is what people coming through to our helpline also was telling us. But we needed this this data, if you like. And, you know, it's not surprising if ever you'd seen your child collapse, and that they had an anaphylactic reaction, you would never want them to have that experience again. You would never want to witness it. You would never want, you know, your child to have those symptoms. It must be devastating to watch your child have those symptoms. So I can understand how worried they must be. The current treatments currently focuses on exposure prevention. So they have to be very, very vigilant, checking labels, making sure that there's no contamination if possible, because they know the devastating effect that it might have on their child. And also be prepared for any emergency. They would hopefully be trained in how to use their adrenaline auto-injector and ready to use it if their child's symptoms were suggestive of anaphylaxis. But in our minds, when we analyse this data, and these parents were telling us this, there is a clear need to go beyond this if we're going to improve the quality of life for the children that have been diagnosed with peanut allergy, but also the quality of life of the parents who are very anxious and worried about their child. Next slide, please. So when asked to rank the most important among 5 potential benefits of any treatment, and at the time we didn't know what that treatment really potentially would look like in the future, because don't forget this was in 2018, and so we knew trials were happening, but we didn't know how far they would get, etc. So we were asked to rank what is the most important thing. 5 potential benefits of any treatment that they might have, and we were surprised that half the parents ranked my child being less worried about an allergic reaction and what might happen to them. So this fear that they are living with on a very constant basis was really, really important to them and the parents who are watching their child being anxious about any allergic reaction. And my child being less anxious socially and having more positive experiences, like being able to go to birthday parties. So many children we hear about with peanut allergy being excluded from things, being bullied, etc. So as a parent, you would want your child to have positive experiences. My child's lifestyle will be less restricted, and I'll have to less to worry about my child having an allergic reaction. So they were ranked also as of importance as well. And my child being able to better fit in with peers and participate in more activities was ranked the least important out of the 5 statements. So the parents are really worried about this allergic reaction and they live with this fear. Next slide, please. So just to summarise, on that one aspect of food allergy, peanut allergy, we know strict avoidance is difficult. There is no good predictive markers of severity. Yes, we have got diagnostic testing in specific IgE to peanut, and we've got skin prick testing that's often done in secondary care, but there are some places in primary care that do skin prick testing where they've got primary care allergy services. But there is no good predictive marker of severity. So you might do those diagnostics, but you will not know who may go on to have an anaphylactic reaction and who won't. So there are no good predictive markers of the severity that child has to live with. So that's why we all children with diagnosed peanut allergy would be at risk. And so children are always at risk of a severe reaction, and that's the reality of it. And living with this fear is anxiety provoking and stressful for the whole family. So we mustn't underestimate the burden of living with peanut allergy. Next slide, please. So what is there out there in terms of how, as a population, we might address some of these issues within food allergy? So we did have some guidelines that were updated and published earlier this year. We have the European Academy of Allergy and Clinical Immunology, bit of a mouthful, but EARCI for short, and these guidelines were on preventing food allergy. So we do know from all the research that some populations are at greater risk of developing food allergy than others. So familial tendency, eczema severity, IgE sensitization, that's all putting people at greater risk. So the guideline examines some of the intervention that could be used for those that might be at increased risk. And those who are in the population that have no eczema or hereditary tendency or familial tendencies such as eczema, asthma, hay fever, etc. And so they might be at general risk of allergy, of food allergy. So how do we try and prevent food allergy developing in those populations. So the guideline provides recommendations for healthcare professionals, and that's why it's really important to know about this, to consider when assisting families to make decisions on how to prevent food allergy, because those conversations really need to be had. So, but the individual circumstances, so you would have heard about cofactors and risk factors, etc. But and you would have heard about how important it is with the clinical history, and that the clinical history will be specific to that individual. So individual circumstances should be considered at all times. Next slide, please. And so the AllergyUK guideline, it does not cover treatment of existing food allergies. So those who have been diagnosed with a food allergy, maybe cow's milk or peanut or egg allergy or shellfish or whatever it is, their food allergy, this guideline isn't covering any of that, because where there is suspicion of food allergy, you would be thinking about it. We have the NICE guidelines on food allergy. You would think about referring to a specialist allergy service for careful evaluation and proper management. And you've heard from some of our secondary tertiary care physicians today what types of things that they can offer within their specialist services. So that's really important, that patients that need that level of support, etc., find their way to those specialist services. And you've heard from our research also that the majority of people with peanut allergy receive their diagnosis from paediatric specialist centres. So it really is, important that patients find their way there if they have got a diagnosis of food allergy. So here the prevention does not cover those who have already developed food allergy. And the recommendations are intended for infants that have not yet developed food allergies. So that's really, really specific and important. Next slide, please. So some of the things that are in that prevention guideline that's been published. So all recommendations about preventing food allergy relate to infants up to a year and young children up to 5 years, regardless of risk of allergy. So that's quite an important thing to note. And the reason why they did that, because there was insufficient evidence in other age groups. So the task force suggests avoiding the use of regular cow's milk formula as a supplementary feed for breastfed infants in the first week of life. So for breastfed infants, really they should just receive breast milk. That's what the guidelines were telling us for some of the evidence that's coming through. The task force also suggests introducing well-cooked but not raw egg or uncooked pasteurised egg into the infant diet as part of the complementary feeding. So that's an important aspect as well. And we have, and you would have heard from our speakers, that we have an allergy society, the British Society of Allergy and Clinical Immunology, and they've just released guidelines on egg allergy as well. And within that, it also mentions vaccines, etc. So that's an important thing to actually find those guidelines. And in populations where there are high prevalence of peanut allergy, they suggest introducing peanut in an age-appropriate form, such as smooth peanut butter, or how the research was done was on like a snack called Bamba, which is a bit like a what's-it type of thing that just melts in the mouth, but it just is covered in like a peanut protein. So that's an age-appropriate form as well, as part of the complementary feeding. So when introducing solids into the infant's diet, then that's one of the things also should be introduced. And the studies actually are saying that the most effective age to introduce egg and peanuts is from 4 to 6 months of life. So many of the the guidance is saying 6 months, but for prevention, if you like. Next slide, please. So the AllergyUK guidelines also suggest against the following. So avoiding any dietary food allergens during pregnancy or breastfeeding. So that means eating a full diet as long as the mother's not allergic to whatever the food is, just a full diet, not avoiding any of the food allergens during pregnancy or breastfeeding, and enjoying the foods that they're eating, and without restrictive or avoidance of anything that is not currently what our public health messages are saying. So also using soy protein formula in the first 6 months of life, that also they don't suggest that happens. So avoidance of soy protein. Because there's no evidence that might actually prevent food allergy. There was no recommendations because the research evidence that they didn't conclude that it was strong enough to either recommend for or against use of vitamins, fish oils, prebiotics, probiotics, symbiotics in pregnancy, or when breastfeeding or in infancy. So they might all have their place, but within these guidelines, the evidence, they couldn't actually give any recommendations for or against it. Or altering the duration of exclusive breastfeeding, or any hydrolyzed infant formula, or regular cow's milk based infant formula after the week of the age of a week, or the use of emollients. So although you might hear about many of these things within the AllergyUK guidelines to prevent food allergy, there was no recommendations for or against it. Next slide, please. So this is the conclusions that I've taken from the prevention guidelines. Introduction of peanut and well-cooked egg as part of complementary feeding. That is something that we should actually go ahead. The research evidence really does support that. And avoiding supplementation with regular cow's milk formula in the first week of life. If that can be implemented in everyday practice, so if there's midwives, health visitors that will be able to take all that forward, what the prevention guidelines are saying, this might actually go a long way to help. Next slide, please. So what are the challenges? What's the risk of a peanut allergy? There was a paper published earlier this year, another one. I'm trying to look at all the up-to-date evidence, and that suggests that age and eczema severity, but not family history, are major risk factors for peanut allergy in infants. And that is surprising because before we thought that maybe family history and eczema severity are risk factors. Well, eczema severity, it is a risk factor, but family history it is not. So if they've got an atopic family, it doesn't necessarily mean that they will develop peanut allergy. And if they haven't got a family history of allergic conditions, atopy, it doesn't necessarily mean that they won't get peanut allergy. So this paper is an important to note. It is the age of the child. So so if people within the family are eating peanuts, and in our society, there are peanuts sort of served in many places, so they're almost ubiquitous within our environments. And so if you don't introduce peanut into the child's diet early enough, then that could be a major risk factor for the development of peanut allergy and also eczema severity. So these two things are really important if we're going down to try to go down more of a preventative pathway in the future. Next slide, please. So what are the challenges? So again, there was another paper produced earlier this year. So early recognition of eczema, that is important. And we've known this for quite a number of years now. And you'll see on many of our things that we, information that we put out about eczema, we use this image of this beautiful little baby with an impaired skin barrier, and it's heartbreaking to see. And we hear this so often with parents that come through to our helpline about eczema and about how broken their skin is, and they've tried so many different things. So it's really important that we step on this very promptly and not leave these children with this impaired skin barrier and not proactively manage it. So the early recognition of eczema as an important route of sensitization, and you would have heard about being sensitized through the impaired skin barrier. So early intervention, early management and early treatments are of utmost importance if we're going to try and help these children, these families. And frequent skin moisturization. So we talk about emollients, but to moisturize the skin in early life might promote the development of food allergy. And this came as a surprise, and this is what the publication earlier this year was all about, is when they did the LEAP study about peanuts, they went on to do what's called the EAT study, which was inquiring about tolerance. And that did, because the LEAP study was all about peanut allergy, but they wanted to apply some of that learning into the other allergens, like things like fish and cow's milk and egg, etc. So that's why they did the EAT study. And there was some early signals that were coming through about the fact that not everyone had this atopic history. But so what they think is perhaps there is some sensitization of food allergens through the skin, the impaired skin barrier. So they're calling it transcutaneous sensitization. And this is currently being explored in much more depth. So hopefully in the future, we might have much more research evidence about this. But at the moment, what the recommendations are, and important to note, to give that information to parents, moisturizers applied, you need to tell the parents to wash their hands thoroughly beforehand, and not to use things like food oils either. So not coconut oil or nut oils, or olive oil, or all the types of things that people use quite regularly. So it's important, that information. Next slide, please. So some of the challenges that we're facing, and improving allergen management. And we've just had a new legislation that's just come into effect about the prepared foods for direct sale. We've got the legislation about the 14 allergen labelling, etc. But there's still some improvement across the food supply chain to stop any cross-contamination, the accurate use of precautionary allergen labelling. We know that there are new and emerging food allergens and pan-allergens that can cause serious allergic reactions, such as kiwi fruit. We're seeing banana, we're seeing lentils, chickpeas. So we're learning as we go along, but we are seeing things that historically we hadn't seen in this way before. So we are seeing new and emergent food patterns. Our diets are changing. There's an increasing consumption of plant-based foods and new protein sources also that are coming into the diets, such as algae and things. You know, and there still remains uncertainty in how to completely prevent food allergy. So there are just some of the challenges. Next slide, please. So what do we want in the future? So wider usage of the milk and egg ladder, using these heat denatured products, because the protein denatures, and so the immune system doesn't recognize it to react in the same way. So it needs to be guided by a healthcare professional that really will know how to differentiate between the IgE and the non-IgE allergy, and to help do this introduction into the child's diet, but under very closely monitored, supervised type conditions that dietitians often help with. Not all of these milk ladders need to be started or done in a hospital setting, and we're learning that now, but it really does need closely monitoring and guidance. So they really do need to have it under a dietitian, which is of utmost importance, because if patients see these milk and egg ladders, they might think that they can just do it themselves and step up the ladder before they're ready. So it really is important that they understand what you know, the advantage, but also the challenges and the risks might be. So we're seeing more of food as medicine now, and who would have thought that? But as we've got these allergic children, and we know that just a management plan alone is not enough to safeguard them. So we are seeing food, medicines developed to try and combat food allergy. So this concept of immunotherapies, a lot of people use it interchangeably with desensitization. So immunotherapy in food allergic patients has proven to provide some real benefits. And as patients have less reactions to just low amounts, so take you back to our survey that we did, the lived experiences, that these parents, what they want is to stop the fear of their child having an allergic reaction. So many of these patients that are allergic to food, in particular peanuts, which are the front runners for the immunotherapy, many of them don't want to eat a whole bag of peanuts or handful of peanuts or anything. What they want to know is that if there was anything, a contaminant or low levels of peanut protein, they wouldn't die from a reaction. And so immunotherapy can pave the way for things like that, reassurance. So there are immunotherapy products, some going through the NICE type process at the moment from the National Institute of Clinical Excellence, with other things in the pipelines as well. So that provides our hope, if you like, on the horizon. And how are they doing that? Well, there's ones that are put in there in the mouth, the oral immunotherapy, and there is a patch technology as well that has been developed, and we call that the epicutaneous patch. But again, that's an immunotherapy as a food, as a medicine, if you like. So dealing with allergy. Next slide, please. So from desensitization immunotherapy, what you're trying to do is to switch off the allergic response once it's developed. So you're trying to reprogram the immune system. So you're trying to change one TH response from a TH response to one where the body doesn't, the immune system doesn't overreact to something that, should be harmless, like a food protein. To the person. So it's switching off that immune response. So it's more of a protection rather than a cure. It lowers sensitivity and reduces risk of serious allergic reactions to an accidental exposure. But to to many of our parents that we surveyed, this is an important point to help reduce living with that fear and anxiety of a food allergy. There may be reactions on the way with some of these immunotherapy products, but sometimes that's a risk parents are willing to take, because if it protects them in the long run, then and it does reprogram the immune system, then risk versus benefit is something for the parents and the children to consider. You still have to keep eating it. So if it's an oral immunotherapy, you need to carry on over time, and we don't know how long that time is. It might be indefinitely, because once you stop, are you allergic to that food again? And we don't know the answer to that. Exactly the same with the patch. If you stop the treatment, how long does that last? So these are important questions to find out in the future. But these treatments are going to come on board, hopefully, because that does provide the hope. And these people still have to carry adrenaline auto-injectors. So the MRHA, our guidance is they need to carry 2 adrenaline auto-injectors. So that's not going to change either. Next slide, please. But what we've got is hope, because as new treatments emerge, that will provide future hope for these people. So, which is quite an enormous thing. And we hear about people living in fear, but it's nice that there might be hope as well on the horizon, because currently there is no cure for peanut allergy. And also for other food allergies, there are no cure. With egg and milk, the majority of children will grow out of them, but there are some that it lasts lifelong, and they will have these allergies lifelong into adulthood. But with peanut allergy, very few of the children really grow out of that, so that is a lifelong allergy. So we need to provide some hope for these children and their families. Next slide, please. So I want to leave you with this, and each one of you do small things in great ways. And when we all do that, hopefully we can make a very big difference to people living with food allergy. And we are a support organisation, and we do our very best to help and support and provide information to people, and also for healthcare professionals to use in their everyday practice. And all our resources are free for you to download, share with your parents, your patients and parents of the children that you look after. And so if there are resources that you think, that's a gap in the resources, please get in contact with us and tell us. And we're always open to those type of maybe we've got a number of clinicians working for us. You've heard from Laura and you've heard from Lydia, both working for AllergyUK. We've got 5 clinicians, 2 dietitians, 3 nurses. So we put together information, but if there are gaps in our information or resources, then get in contact with us and we can try and address that gap. But just leaves me to say thank you very much. Thank you, Laura, for the invite to talk today, and thank you very much for listening.
Thank you, Amina. Like you say, it's really important, hope on the horizon for our food allergic public. So yeah, very important. We do have a couple of questions that's come in. If anyone else has any more, please add them to the Slido platform as soon as possible, and we'll try and answer them. So we're going to start off with one that's maybe a little bit controversial, as expected. So we know in the IACI prevention guidelines, it says no formula in the first week of life. as a dietitian, I do allergy focused histories, and I often see that pattern. They have it in the first week of life and then not after. They carry on breastfeeding. So the question is, what happens if that person cannot express or exclusively breastfeed for the first week of life? I suppose, how does that make the parent feel in that situation, but also how to interpret that information from that guideline?
Yeah, thank you for that really important question, because to me that's not controversial at all. That is true life, and there will be a lot of people that won't be able to fulfill that. Unfortunately, there might be times when their baby's on special baby care unit, or they've had a cesarean and they can't, that true life has to reflect all probabilities and possibilities. These guidelines are very generic, and for the majority of people, they might be able to, comply with that. But for those that can't, I don't think any mother should be made to feel guilty for their choice, because it might be the mother's choice as well not to breastfeed. And so I think what the guidelines are trying to say is that if you've started breastfeeding, don't introduce the cow's milk formula in the first week of life, just the general cow's milk formula in the first week of life, if you can help it. And if you choose to formula feed the child, don't stop, if you like. So I think what they're trying to convey is that stopping and starting within that first week of life. And also one of the reasons why they're trying to increase levels of breastfeeding, because we've got one of the lowest levels of breastfeeding. So from a public health perspective, they want to increase breastfeeding rates, etc. And of course, within the first few days of life, you've got the colostrum that comes out, and then you've got the mother's microbiome as well that's coming into the breast milk. So there's all sorts of positives as well. But I do feel very strongly that we should never, ever make a mother feel guilty for either choices or whatever happens within that birth experience and just after.
No, I totally agree. Allergy is one aspect, but real life, as you say, is another aspect. So we've got lots of guidance. For example, have a normal diet in pregnancy, introduce egg and milk early, or in the diet, in the weaning diet. So all foods really in the weaning diets to prevent allergy. But what happens in the case of a vegan mum? What's, introducing something once and then not again, or how does that a vegan mum feel if she feels that the evidence presented to her, even in pregnancy? How do we address that situation?
Yeah, that's another very interesting question, Laura. You've got some great ones lined up for me. Thank you. But in the vegan household, they might not be eating egg anyway, and so it's also about their normal household diet, etc. So when we've seen about risk factors, eczema seems to be a big risk factor, and the age of introduction, etc. But there will be a lot of foods that won't be introduced early into the vegan diets that are of the 14 allergens, if you like. And so, but that won't be part of the family's diet anyway. So whether that becomes, sort of a risk later on, if you like, at 5, when they might go into school and come across egg, etc. I don't know the answer to that, because vegan diets in the UK are only becoming more and more popular within the last few years. So we don't know how that's going to pan out in the long term.
No, absolutely. So there's just a couple of eczema questions, and obviously there's been a theme throughout the whole of today for eczema. But is adding coconut, vegetable or olive oil to the bath acceptable rather than rubbing it on the skin?
Oh, that's a very, very good question, because because there at the moment we haven't got enough evidence, if you like, about what is the mechanism of the oil to that might cause the sensitization. Is it the fact that it's a food oil that you're rubbing in and you've got all the hair follicles, etc.? There's only a hypothesis. There's not, you know, the evidence, if you like, to make any strong recommendations on what the mechanism actually is. So at the moment, they're only talking about rubbing it directly on the baby's skin.
No, absolutely, absolutely. And it's difficult, isn't it, trying to get all those answers. Someone has highlighted also kind of the media attention around emollient use and the impact on sensitization through the skin, that they're worried that that means that children with eczema are going to decrease their emollients. So I think probably you recognise that as a problem.
Yes, and that may, because emollients are a mainstay of treatment of eczema. So, you know, it's important to moisturize that skin. But one of the reasons why we're saying about emollient use is because hopefully they won't contain any of the food things, because what the a big problem is if you get sensitization through the skin before you actually develop oral tolerance in the infants, then that's how they think maybe the food allergy can develop. So by not using the food moisturizers like the coconut and the nut oil and oats and things like that, then that would be the best practice.
No, absolutely. Thank you very much, Amina, for your amazing talk today. It really is good to have hope on the horizon. So we really appreciate it. So that brings us to the end of today. Thank you for everyone that's joining, asking your questions and being interactive in the day. It's been a pleasure having you. We'd really appreciate it if you could complete your participation survey afterwards. You will get certificate and CPD points. The recording, so there's been a few questions come through about the slides. The recording from today will be on the AllergyUK website in the next few days. You can watch it back afterwards and see the slides again. So hopefully get all the information that you require. I'd just like to say thank you to all the staff at AllergyUK behind the scenes. The speakers and presenters today have been amazing. The staff at Attendable who have done all the tech issues today, and our sponsors Immune and Nutricia. We appreciate the support. So just moving forwards, we have got some other webinars coming up later in the year. We've got one on the 9th of November on chronic spontaneous urticaria. That's a short session. And the 1st of December, allergic skin disease, atopic dermatitis and chronic spontaneous urticaria. We really hope that you'll sign up to them and join us. And we thank you for your support at AllergyUK and hope to see you soon.